This is the last long chapter, second to last chapter on the entire course. So pretty stoked to get this one out of the way because the next one is, I usually spend about 10 minutes in class covering the chapter 16. So chapter 15, I usually run out of time before I can cover all of. So this will be interesting. So it's kind of late. It's a little after 11. I'm hoping that that'll make me speed things up and go quickly. This is a little bit of a dry chapter. Can't really pepper in a lot of stories in this one, I don't think. But this is very important if you're interested at all in the field of psychology because it covers, I wouldn't say all of the psychological disorders, but all of the big categories of disorders. So a couple things we're going to talk about. Don't worry about that. All right. So here's the thing. I'm not a particularly PC person. I absolutely hate the world that we live in right now and this whole cancel culture and everybody, dancing on their feelings, and it's ridiculous. But the one exception to that, the one soft place that I've always had kind of in my heart is people who suffer from a mental illness. I've experienced firsthand what it's like to deal with somebody who suffers from depression. It's horrible. I have experienced firsthand many people that deal with schizophrenia, which is literally a living nightmare that you never wake up from. I just can't imagine. As bad as your life might seem, you run into somebody who's even has a decent, they have a family that takes care of them, and they're not on the streets or anything like that, but they suffer from schizophrenia, and it will put your life into perspective. I promise. So with that in mind, I am a little bit more PC when it comes to mental illness things. So people have a tendency to label somebody according to their diagnosis. Oh, you mean that autistic kid? I've heard this tons. So I was at, not to throw them under the bus, but Magnolia School District, which is a great school district, by the way. I was there for almost a year getting my credentials to become a teacher, thinking that maybe I wanted to do that at the high school level. Huge waste of time. But I basically taught special ed, and I kind of had my own designation. It was a long story, but anyway, I dealt with all of the kids that had anxiety issues, depression, things like that. They came to my room. It was like a testing center. Basically, I ran a testing center for people that had accommodations for a more intimate setting with fewer people and whatnot. And so sometimes people wouldn't show up for exams or quizzes or whatever, but the teacher had scheduled them to. And so they would say, "Hey, did John come take the test?" And I would say, I got the whole school. Who's John? And they go, "Oh, he's that little autistic kid." And that always offended me. Who wants to be labeled by one characteristic of their personality or their physical stature or something like that? I just think it's really rude. It's very short-sighted. There's a difference between saying Gage is an autistic child or Gage is that autistic kid versus Gage is a child with autism. So now they're not defined by their disorder. So I'm a little bit hypocritical on this because other things, like when we talk about victims of certain things, and they call them survivors, not victim, and I'm like, oh really? Their life wasn't in danger, so we're really calling them survivors. So I get a little hypocritical about it. But anyway, moving on. Basically, the bottom line is try to avoid labeling somebody as best you can, especially with something like mental illness, which is kind of a stigma in and of itself. The other thing here to talk about before we start talking about all these diagnoses is something called medical school syndrome. Medical school syndrome is what often medical students will go through whenever they start learning about diseases and symptoms, and they start diagnosing themselves with everything. Right? Oh, that happens to me. I think I have that. Or even worse is, oh yeah, that's my brother. My brother's got that. Oh, that's my mom. My mom is definitely that. Oh yeah, that's my husband. That's my wife. Whatever. You start labeling everybody, right? Well, just to put this in perspective, this is an introduction to psychology. This is a one-chapter overview of an entire book that's 400 or 500 pages long that takes 6 or 7 years of graduate school. then 2 years of full-time training to even sit for the state board exam, which is not particularly easy, not that I've taken it, but what I hear, just to be able to make those diagnoses. So please don't think that you're going to hear one PowerPoint slide of a disorder and have any kind of weight behind a diagnosis to yourself or somebody else, right? Please understand that in the DSM, which we'll talk about, which has all the criteria for these disorders, they're all pages and pages long, most of which filled with jargon that you probably don't even understand and would have to look even that up. So just avoid trying to label yourself or somebody else. Now, if you're hearing these symptoms and you feel like that might pertain to you or somebody that you love, then I would encourage you to encourage them or yourself, go get checked out by a professional. Okay, go to an LPC, go to a licensed psychologist, go to a social worker, somebody who is licensed and understands the nuances of the criteria involved in the diagnosis. But please don't run to your private care physician and say that you've been diagnosed with XYZ and you need meds for it. Hopefully they're not going to take your word for it and they're going to want a doctor's name, but don't go medding yourself up because you think you have something, okay? By the way, that's my son. Isn't he cute? All right. All right, let's talk about the notion of abnormality. Okay, so before we can diagnose somebody with a mental illness, right, essentially what we're saying when we do that is that this person is abnormal. That's not a particularly pleasant thing to be, right? There's kind of a negative connotation just in and of itself, right? I would say in a lot of ways, I'm completely abnormal. We look at intelligence, I'm abnormal. If you look at degrees, I'm abnormal. If you look at, I don't know, lots of probably different things, right? I'm abnormal. Now, you could look at your own life and find probably a dozen things that make you abnormal. So what does that really mean? Well, all that we're saying, if we really break down the word abnormal, right, comes from the Latin ab prefix, right, which simply means away from, and then norma, which means the rule. So the word abnormal in Latin literally translates to just away from the rule. Okay? So what is the rule? Okay? Well, the rule here is that we put ketchup on fries. That's kind of the rule, right? They offer you ketchup most of the time when you have fries, or they just give it to you expecting you to want it. Now, they're really good fries. You might not want to put anything on it. But if you put anything on it, it's probably ketchup. Somewhere along the way, ranch dressing started working its way in. There's tons of people that dip their fries in ranch. Hey, I'm one of them. So I don't think that's particularly abnormal now. But a while ago, 20 years ago, my parents, that's super weird, right? Who does that? Anybody watching this video dip your fries in mayonnaise? You probably somebody watching this went, ugh, gross, right? So I was at an airport one time, had a layover in Amsterdam. And they had a little McDonald's, and it was one of the few things open. I'm not a huge fan, but I was like, it'll do. So I went and I got a little, whatever it was that I ordered. And instead of giving me the little packet of ketchup, they give me a little package of mayonnaise. And I laughed because I just figured, they grabbed one out of the bin and it got mixed in, or they grabbed it from the wrong bin or whatever. And I went up there and I was like, can I exchange this for ketchup? And I don't think they had any. Or maybe if they did, somehow we had a conversation at the counter and they're like, American. What does that have to do with ketchup and fries, right? This is how culturally ignorant I was at the time. That's what they put on fries in Holland, is mayonnaise. Yeah, it's disgusting, right? But that's normal there. Now, if you do it here, it's abnormal. So is abnormal really bad? It's really not a bad thing to be certain kinds of abnormal. It just simply means different. You're away from the rule. Most people here in America use ketchup. If you use mayonnaise, you either live on that side of the world where it's normal, or if you're here doing it, it's abnormal, right? So it's a very subjective term, I guess is what I'm getting at. Historically, I can tell you that, and I should probably look up the year so I could put this down, but homosexuality used to be considered a mental illness. And the reason that it was considered that is because basically the scientific community felt that we are engineered to be attracted to the opposite sex, hence procreation can happen. Two men can have a baby, two women can have a baby, so it sort of defies evolutionary logic to say that should be a thing, right? We don't see it much in the animal kingdom, so again, it just makes sense to think that we're engineered that way, right? So if for whatever reason you're not, if you are attracted to somebody of the same sex, well then you are not normal, right? And so you are abnormal, and therefore it is considered a psychological disorder. Now, it was considered a psychological disorder because at the time, again, very abnormal, right? Well, a little time has passed, we've grown up a little bit, we've matured a little bit, and we realize, it's much more normal than we thought. People are living in the closet, and now everybody has come out of the closet, right? I'm firmly convinced that there are people that are out that aren't even homosexual, but there's so much attention to it right now, right? And there's people are held in such high regard. You're revered as a hero, right? We have a lot of people in early puberty that are coming out and professing to be homosexual, especially in sort of the marginalized people that don't really have a lot of friends. They're kind of misfits. They don't really fit in anywhere, right? So they're like prone to being bullied. And so what happens? They come out and they say that they're homosexual. Well, even bullies know you don't bully somebody because they're gay, right? That will get you on the news and sued and kicked out of school for God knows how long. Now, one kid beats up another kid because he's skinny or weak. That's just kids being kids. You have detention for a couple days. You beat up that same kid because he says he's gay. Now it's a hate crime, right? Huge big deal. So I've read a lot about people that are coming out now just because they want to be accepted, and it's socially unacceptable not to accept somebody who's homosexual. So yeah, we have a very weird time right now that we're living in regards to sexual orientation. Of course, I want to say it was the late 70s, they ended up taking that out of the Statistical Manual of Disorders as a diagnosis at all. It went from being a diagnosable mental disorder to it's not even in the book, right? And so you'll see some other examples of, as a society, we start deciding more and more what's normal. And we start changing our definition. And as we change that definition, you see new disorders come into play. You see older disorders kind of fall out of being even disorder at all, or they sort of morph into kind of an in-between area like gender dysphoria, which I'm pretty sure we'll talk about. So I'll skip that and get to it when we get to it. All right, so this notion of abnormality is something to really keep in mind whenever you're explaining this kind of thing to a client, because nobody wants a disorder label, right? But the fact remains that there are people that need assistance. There are people that need to be educated. They need to be given tools to deal with certain issues, and these issues fall very clearly under specific criteria with labels. So, it is what it is. I don't think that I qualify for any of the disorders, so it's hard for me to really say, oh, I know how that must feel, but, it is what it is. If I had diabetes, or if I had, some, male pattern baldness or something, whatever it might be, well, that's the cards I was dealt. That's my genes, or, whatever it is, and, you move on about your day. Perhaps that's because there's not as much stigma in America as, male pattern baldness as, schizophrenia or something like that. So, anyways. All right, so psychological disorder, this is a very long definition, but it is very much all-encompassing. So this disorder this definition has so many pieces to it that I want to break it down kind of piece by piece. All right, so the definition given to us is a clinically significant, let's stop right there. All right, this goes back to what I said at the beginning, right? It has to be clinically significant, right? If you're like, I'm kind of sad today, and somebody's like, oh, you're diagnosed with depression. No, that's not really how that works. Okay. So there's a difference between being sad and being depressed, clinically depressed. Um, when it says clinically significant, what that means is there's a criteria list, and you'll see that whenever I start showing you the disorders. You'll see there's like a long list, and you have to meet so many of them, right? There's 15, and you have to meet 7 of the 15 in order to be clinically significant. Or it has to persist for a specific amount of time. It can't just be you woke up one day and you feel sad, oh, you're diagnosed. Even if you do meet 7 out of the 15, because tomorrow you might feel better. And if that's the case, you're not clinically depressed. So that term just in and of itself, clinically significant, is a huge part of this definition. That makes a huge difference for a diagnosis. So clinically significant, behavioral or psychological, again, that right there, that's pretty huge. Your behaviors can be abnormal, and your psychological reasoning can be abnormal, right? You can have maladjusted thinking is what we call it. So it can be behavior or psychological, syndrome or pattern that occurs in an individual and that is associated with present distress. Okay, that "and" right there is hugely important. Okay, so we have clinically significant, meaning we have to meet a certain number of things on this checklist. It has to persist for a certain amount of time, right? It can be behavioral or psychological. We got that. Pattern that occurs in an individual, and it has to be associated with present distress or disability, or, so there's your "or," right? With significantly increased risk of suffering death, pain, disability, or an important loss of freedom. So, what if you are, and we haven't talked about it yet, but what if you are somebody who is agoraphobic? An agoraphobic doesn't like to leave the house, okay? That's the number one kind of symptom. So let's say that you have a job, you're tech support, and you do your job from your home. You don't go into an office building or whatever, and you make pretty good money, right? So nowadays, you have Grubhub, right? You get all your food delivered to you. You can order your groceries, have them delivered to the house, right? I mean, you can get darn near anything on Amazon, have it delivered to your house. Your job is at your house. You play online games, and you pull up a little window like this. It's got 4 of your friends, and you're interacting with them and playing your game, and you live a great life. You're happy. You're paying your bills. You're contributing to society. You have good social friends. If somebody asks you how's your life on a scale from 1 to 10, you'd rate it a 9 or a 10, right? Everything is great, but you hardly ever walk out that front door. And if you had to, it would cause a pretty significant amount of anxiety. So, is that clinically significant? Well, yes, because you probably meet enough of the criteria to say that it's clinically significant. Is it abnormal behavior? Yes, right? Most people are not freaked out by having to walk down and pick up their mail at the end of the street or something, right? So not a big deal. But in this case, I would personally hold off on that diagnosis because it is not presenting distress. That is very important. Please understand that. So in this situation, clinically significant behavioral or psychological syndrome or pattern that occurs in an individual and that is associated with present distress. Well, in this case, it's not. So it is not a psychological disorder. I call it more, in this case, I would call it more of an eccentricity, right? It's eccentric. That person doesn't like to leave very often, but they've accommodated, right? They've dealt with it. There is no real distress. Now, as a clinician, you have to kind of weed through the bullshit, right? Because people will come into your office and they will say that they're fine, but their relationships are crumbling. They're losing job after job after job. They sort of do things that are not particularly normal, as in maybe they're very depressed. They've given away a lot of their belongings. They used to be on a bowling league, but they stopped going. Whatever it might be, right? But then they tell you, oh, everything is great. So we call that malingering, all right? Malingering just means lying, basically. So you have to it's very much an art form, right? You have to look at the criteria and say, that's definitely agoraphobia. But then you have to evaluate what they're saying. They're saying, well, they're saying that there's no distress, but I don't really believe them. I mean, they're losing jobs and they're not this and they got that. So in that case, I diagnose it. But if I really believed them, I did not think that there was malingering occurring, and I believed that they were very happy, they were just sort of an eccentric person, then I would not label them with the diagnosis. So, again, lots of pieces to this particular definition, but all very, very important. So, here's a question for you. Can you be abnormal without having a psychological disorder? I'm looking around the classroom, my pretend classroom. Ah, yes, you back there. What do you think? You think you can be abnormal and not have a disorder? Well, you're right. If anybody out there still after the age of 5 puts ketchup on your eggs, you're abnormal. Okay, that's weird and gross, and the chef should come out and smack you in the head, right? It's definitely abnormal, right? We have all kinds of things. Like I said earlier, we all have things that we do that's abnormal. But it doesn't constitute having a disorder. I used to, I'm kind of over this for the most part now, but my son has something called sensory processing disorder. And when he was young, it was very prominent. It was very obvious that there was something different about him. As he's aged, he's now 13, he's just as normal as anybody else. You would never know this about him. But at the time, it was very eye-opening, and I did a lot of reading about it because I had never heard of sensory processing disorder. In grad school, we never even talked about it. So, not a ton of research about it. Pediatricians will sometimes know about it, but even then, they're usually fairly misinformed and undereducated about it. It falls under the purview of occupational therapy, believe it or not. And basically, there was a lady that kind of discovered it, if you will, as a neurological disorder, and it's just what it sounds like, sensory processing. They don't process their senses well, right? Some of them have a very, very high pain tolerance, like ridiculously high. Step on a nail, and they just kind of go, ow. That we're supposed to have a pain reaction to something like that, right? That's the normal way to be. Feeling hot, feeling cold. Things like that. I mean, this feeling of homeostasis that we should be able to maintain sort of, without any kind of thought or whatever, sensory processing people, maybe not. So like my son was a little rough. He would play, he didn't know his own strength. I remember one time I had a new watch and I was like, hey, you want to see, I had a little gadgety stuff on it, right? And he reached over and grabbed one of the little dials and just yanked it off the watch. And I was like, dude. So I sent the watch back and, I told him what happened and they were nice enough to send me a new one. And I showed it to him again and he reached over and he was just about to do it again. But I learned my lesson. So I'm like, no. He just doesn't know his own strength, right? Something that any little kid could do, but it happened a lot with him. So we had to be very mindful of telling him, like, look, that's too hard. Or somebody would come up and touch him from behind and he would spin around and get mad and say that they had hit him because he wasn't processing that tiny little tap. He wasn't processing that properly, right? That tap was somehow being processed in his brain as one of those. So anyway, the reason I'm telling you this is because it's genetic. And I started going, well, that means he got it from either me or his mom, right? Like, he didn't just catch it from being in the nursery at the hospital. Like, where'd it come from? I don't have that. So I started, again, reading more about it, learning more about it, and realized my whole life I had this. Never knew it, right? Nobody ever diagnosed it. I guess I was just a weird kid and never noticed. But I would distinctly remember when I was a kid, I had to be even all the time. So if I kicked into the coffee table and stubbed my toe, right, like one of the worst pains that I can imagine, I would then on purpose kick my other foot on that same coffee table leg, just so that I would be equal on both sides. So, very abnormal behavior, right? Clearly, we're not wired to injure ourselves just for the sake of, being equal. Somebody would, my grandfather would come up behind me and he'd kind of put his hand right here and he'd go, hey boy, how you doing? Just from behind, and then walk off. And now I can still kind of feel that because he was a really strong guy. So I would feel, that just the pressure, from where he had touched me. And I would kind of reach up and I'd squeeze this side just so, this side feels the same as this side does or whatever. I mean, that's weird, right? It's abnormal. I kind of aged out of that to a large extent. It used to bring a lot of anxiety if I didn't equal myself out on both sides. Now, every once in a while, something like that will happen, and I'll kind of catch myself doing that. I remember when I first started driving, the seatbelt would kind of hit me right here because I'm kind of tall. So it hit me on my neck, and it would kind of hurt. And when I get out of the car, I would feel that, and I would just kind of go like this, and I would scratch my neck on this side. So anyways, very abnormal. None of that, by the way, under the current or even back then diagnosable disorders, did it fall under any of that. All right, it was not considered psychological. It still is not considered a psychological disorder. So we can be abnormal and not have a disorder, right? We have our weirdness. Now, can you have a disorder and not be abnormal? That's interesting. If you look at the prevalence rates at all of these disorders, you're going to find that they're from like 0.5% of the population up to maybe 7 or 8% of the population. And if you remember the little bit we talked about the normative curve, right? 68% of the population falls within one standard deviation of the mean, right? So if you're in the 7th percentile, right, only 7% of the population has it. By definition, you're several standard deviations away from the mean, at least 2, right? So again, just by definition, if you have a psychological disorder, you are a statistical outlier and therefore meet the term abnormal. So yes, you can be abnormal and not have a disorder, but if you have a disorder, by definition, you are abnormal. Okay, I hope that all makes sense. Okay, these definitions imply a statistical vantage point for normalcy. That's what I just covered. This has the advantage of being precise, clear, and objective. So that's the reason that we stick to this, is because remember all the way back to chapter 1, is psychology a hard science or a soft science? We want to be a hard science. Well, if we have a subjective notion of what's normal and abnormal, right? What is a psychological disorder and what is not? And we have some clinicians saying, yes, this is abnormal behavior and therefore diagnosable, and we have other people saying, yes, it's abnormal, but I'm not going to diagnose it. I think he's just eccentric. Then we don't really have any basis of comparison, right? But if we compile numbers about who's got what symptoms make up what disorders, and we have multiple people doing research on these things, multiple institutions, right? Decades and decades of research on these things before they make it into the book as a disorder. And with a whole army of people that are, reviewing the rules and the criteria, now we can compare apples to apples, right? So now this clinician and this clinician have a very clear, precise sort of rubric to go by. There's a mosquito flying in here. Oh, that's going to bug me. I'm going to be swatting in a mosquito. I promise that's not just me being weird. There's a mosquito. Okay, so moving on. First couple slides gets us slow going. I'll get going faster in a second. All right, so let's see. Statistical definitions have some drawbacks. It does imply a cultural specificity. So I mentioned this before in the IQ chapter. Black culture and white culture, if you look at their IQ scores, they're about a standard deviation apart, roughly 10 points. And that is not by any means to say that blacks are not as intelligent as whites, or whites are superior to blacks, or anything like that, right? Anything silly like that. It simply shows there is a cultural bias in the test, right? It was written by a white guy. It's been studied by mostly white guys in a predominantly white America, that has not been reflected in the test questions or the design of the test to incorporate, different cultures. So, of course, they're not going to do as well. If I went to Germany, right, and I took a test over there, I'm not going to do as well because I don't understand things that are like, common vernacular to them, right, or I don't even know what that is. So I'm not going to do as well because the culture is different, right? It's not, they're smarter than me, and they're, we would have white and white. So it's not even, it's certainly not a race thing. Other things, again, about cultural specificity. What about things like hearing voices? In some cultures, they'll talk about hearing voices, and nobody looks sideways at that. That's pretty normal. It's even sort of revered, right? If you say that you're hearing voices and the gods are speaking to you and telling you this and telling you that, you're the wise man of the village, right? You've been anointed, right? So we obviously don't think of it that way. We hear that here and we're like, that dude's crazy, right? So again, culture comes into play. Um, Finally, there is no model of ideal behavior. So we talk about stuff like drug use. It's interesting to hear, if I remember when Clinton was running for president. I know that makes me sound super old, but I remember when he was running for president, and they asked him if he'd ever smoked weed. And being the politician that he is, because he had smoked weed, he said, well, he did puff a marijuana cigarette, but he didn't inhale it, so it didn't really count. So he's trying to straddle the fence. He didn't want to say, I've never done a drug, and you got a lot of voters that, are 420 friendly that don't want to vote for him because he's a square, right? So he wants to appeal to those people, but you also don't want to run off your conservatives and say that, I smoked a little weed, right? And then you're like, well, how can you run for president, right? So, brilliant politician that he was, well, yes and no. So now everybody's happy, right? But it's interesting to me that he can't even mention actually inhaling and trying marijuana one time back in his youth. But then we look at some of our role models, right? Johnny Depp, what drug has he not tried, right? Any rock and roll person from any era, right? Ozzy Osbourne, welcome guest on any talk show he wants to go on, any guest appearance that he makes, he gets, standing ovations and all that. And the man wiped his brain out many, many years ago through drug use, and it's like he's still a hero. So depending on your occupation, drug use is either expected or absolutely not tolerated. Does that make any sense, right? So, hell, if within our own country we can't even decide what our stance is on weed, it's legal over here, but it's still illegal over here. And over here, people went to prison for life over it, but over here, not even illegal. Over here, well, you just have to get a card for it, right? We don't know what's ideal. We don't know what's good, what's not good. Sexual behavior, same thing, right? If you've never been with anybody, then you're some kind of prude or weird person for holding on to your virginity until, your 30s or something. But then over here, if you've been with 100 people, then you're just a big hoe. So, what's the right number? What's the number that's not too big or not too small? What is that magic number? Well, nobody's going to give you that, right? So, there are some problems with coming up with notions of abnormality, because that means we have to kind of agree on, well, what is considered normal. And you'll get these discussions amongst clinicians that are maybe on different parts of town of what's normal versus what's not normal. All right, failing to adequately capture the accompanying distress. Okay, so I mentioned that already. Okay, important term here, comorbidity or comorbid. Comorbid is simply the presence of two or more disorders in the same individual. And you might think, oh, that's uncommon, right? It would be uncommon to go to your doctor and him diagnose you with some disease and then say, oh, by the way, you also have this other disease, right? Typically, you only have one. Typically. Well, it's not the same with mental illness. And if you think about it, that makes perfect sense. If I told you that you had any disorder, whatever it might be, right? Dyslexia. It could be something fairly small, like a learning disorder, right? Or it could be something big like schizophrenia. Don't you think that that would maybe make you kind of depressed? Wouldn't you be kind of sad to know that you have a chemical imbalance that for the rest of your life is going to be only minimally managed through medication? It would suck, right? I'd be depressed. So depression is comorbid with other things very, very often. Also anxiety. Knowing that you have this disorder, what's that going to mean for your life? What's that going to mean for your relationships? What's that going to mean for, you being a parent? What's that going to mean for you holding a job or a career? Is it going to get worse as they get older? So many questions, right? So many very relevant, very appropriate questions that you're not going to know the answer to. So do you think that might cause some anxiety? So we see a lot of anxiety, we see a lot of depression, comorbid with all of the other disorders. So it's very, very common to have comorbid diagnosis. All right. I've mentioned this like 10 times now. We finally get to the slide. So this is the DSM-5. It is the Diagnostic and Statistical Manual of Mental Disorders, and it is in the 5th edition. It was first published in 2013 by the American, well, it wasn't first published. It was published in 2013 by the American Psychological Association. What sucks about this is I went through grad school with the DSM-4 TR. So this is the book that I learned for 6.5 years. Right after I graduated, they went to the 5. So I was like, crap. If I'm going to get licensed, now I have to get licensed under a book that I've never even opened. And they were dramatic overhauls, not just in the criteria, but the whole structure of how you deliver a diagnosis was completely revamped from what I learned. So that presented a pretty huge challenge to me ever getting licensed, which is part of the reason I didn't really pursue it. All right, so this book was first published in 1952. Certain disorders have caused sort of what they call a false pandemic. I know specifically ADHD, when that entered into, I want to say it was a DSM-4 perhaps, all of a sudden every kid in America had ADHD, right? It was like you couldn't throw a rock and hit a kid. By the way, I don't recommend throwing rocks at kids, but that's just a saying. So I don't think that you could look anywhere and not see a kid that, oh yeah, he's ADHD. Yeah, he's fully diagnosed. Yeah, he's on Ritalin. Ritalin was a household name. Everybody knew the drug that combats ADHD. It was just that common, right? Pediatricians were diagnosing it. Of course, every psychologist was diagnosing it because there were a grouping of behaviors that were listed in the criteria that are pretty common to kids, especially kids that were getting in trouble or not behaving the way the other kids were behaving. The kids that were misbehaving often would misbehave in the same manner. So you sort of saw this syndrome of behaviors of the misbehaving kids. And so now we can say all those kids misbehaving, they all got ADHD, right? Well, all the research started, pouring in that, oh, this is horribly overdiagnosed. It's not nearly as prevalent as what the diagnosis would lead us to believe. The medication's flying off the shelves. Doesn't need to be. So we kind of had to reel that in a little bit. So it's just one example of, when these books come out, they're kind of good, kind of not so good. Sometimes they have to, print, not retractions, but they sort of have to shore up the criteria just a little bit. It is still considered the best of its kind. So if you look at different Canada has its own version of the DSM. Europe has its own version. The World Health Organization has its own version. And when you compare them, and I've actually done a little bit of this, I've compared like 4 different diagnostic criteria for the same disorder. They might call it a slightly different name, usually not. If one's got 15 criteria, the other one may have 14, one may have 16, the other ones may have 15. They're the exact same things. They're just literally reworded. It's almost as if somebody took the DSM and just said, well, we don't want you to plagiarize it, so just flip around the words, but make it mean the same thing, and then just put it in this book. So it is very much on par with as good a book of its kind of anything you'll find anywhere in the world. So that's good news. Let's see, no specific options available to medical professionals. So we talked about PET scans and MRIs and things like that. You can't go to the doctor and say, I think I'm suffering from anxiety. Can you give me an EEG and tell me if I am clinically diagnosed with an anxiety disorder? You can't go get an MRI to diagnose you for schizophrenia or something like that. So there is no perfectly objectionable, that's not the right word, objective is what I meant to say. There's no perfectly objective medical device that can give you a diagnosis of any of these things that are in here. So that's why being a clinician is both being a scientist and an artist. I really feel that because, again, you have to be able to stick to the science and understand the disorder and understand the criteria and understand, what questions to ask and how to interpret the questions being answered to you. And you have to be able to kind of read between the lines. You have to kind of, dig through the words and really get to the meaning that they're trying to give you. So there's a little bit of interpretation involved. But I do feel like this is a pretty good system. So It gets revamped every roughly 10 years. So, been around for a little bit. All right. And just real quickly, historically, abnormal behavior was always explained through the supernatural. People were possessed, they were witches, they were, um, you know, whatever. A lot of times religious overtones. Um, we've talked about various perspectives in psychology, right? There's an evolutionary perspective. We have evolved into the way that we think and act because of certain, history. There's certainly biological imperatives behind certain behaviors and thought processes. Learning psychology, developmental psychology, cognitive psychology, individual, social, just to name a few, they all think that they have the answer, right? So that word etiology, right? That just means, where does it come from? So the etiology of these disorders, right? Everybody is going to frame the etiology from their particular perspective. So you ask a biological psychologist, right? You ask a neuroscience psychologist, where does schizophrenia come from? And they're going to talk about lesions in the prefrontal cortex. They're going to talk about dopamine levels. They're going to talk about malformations of certain parts of the brain. They're going to talk in terms of science and biology because that's what they do. Now, you talk to a social psychologist and say, where does schizophrenia come from? They are going to give you a completely different answer, right? Now, if they're a hardcore social psychologist that has the inability to look past that, which most people don't. Most people are somewhat cross-trained in different fields and they're accepting of parts of other people's studies, right? But nobody wants to give up all of it. So they will give you reasons, social pressures, things like that, and they'll give you a social psychology answer to where does schizophrenia come from. So what the book does, what the DSM does, is it kind of looks through all of these explanations. Remember I said there was like an army of people that puts this together? Well, I wasn't kidding. There really is that many people. And they have all these debates and argue, and they look at all the research and like what really holds weight versus what's completely theoretical, and they sort of blend the explanations together, and they give that to you in the DSM, and they'll say, well, from a biological perspective, we think this is probably true. From a social perspective, we think this is probably true. From a cognitive perspective, we think this is probably occurring. So you get, as a clinician, you get kind of a well-rounded, blended approach from all these different perspectives. All right, so let's dive into the disorders. So the first category of disorders are anxiety disorders. Anxiety can be broken into two big components, right? The first component is strong negative emotions, okay? That is always present, okay? Negative emotions can be anger, can be sadness, can be jealousy, right? So we talked about those 6 basic emotions that we can boil things down to. Well, this doesn't have to just be the bad ones of those 6, right? We're back to where we can mix them together. So jealousy, disgust, discontentment, anything that's negative, basically, right? That's an emotionally based, thing, a feeling, is part of anxiety. The other part of it is physical tension due to anticipated or perceived danger. So we have a physical component, we have an emotional component. Now, this is different than just straight up being afraid, all right? Because with fear, if you look at just the word fear and we say, like, oh, I'm afraid of that, right? There is usually some sort of an immediate threat. So if you are at work and you start seeing layoffs happen and you are just unable to sleep at night and you're worried about losing your job, that's not really, that is anxiety, but it's not like a disorder, right? You have a legitimate fear. Your job is axing people left and right? The economy is going into the toilet because of the stupid pandemic, right? Companies are laying people off left and right. People are out of work. Unemployment is like way, way up right now. So it is a very legitimate thing to be afraid of. That's not something you would probably diagnose as a disorder, right? Because, again, you have a legit fear. With an anxiety disorder, the disorders featuring anxiety that's not proportional to their circumstances. So this would be like if somebody embezzled $100,000 from the bank that you work at and then got fired, and then you're worried, even though you've done nothing wrong. Well, they're firing people. Oh my God, they're firing. I might be next. I might be out of a job. Because, whoa, 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 whoa. Oh, that's crazy, right? He did something to deserve getting fired. He didn't just randomly get the axe, right? He broke the law. He broke company policy. He violated it all. He's gone, right? You have done nothing wrong. Are you planning on doing something wrong? No? Okay, then what are you worried about? If that person could not shake that fear, that might be a little closer to an anxiety disorder. Um, it's an exaggeration of the normal, useful response. So being afraid, having a fear response is useful. Remember, we talked about that a couple chapters ago. It produces adrenaline. It produces sort of a physiological effect, that increased respiration, increased heart rate. It allows for you to sort of focus on the problem and either fight through it or run away from it. All of that stuff is useful. That's all born from fear. So you get somebody that's like an MMA fighter or whatever, and maybe they go to training 5 days a week. So 5 days a week they're putting on gloves and putting their dukes up and trading blows with somebody, and then you bump into somebody at a bar and they turn around and they put their fists up, and that's just your common. That's a Thursday for you, right? Like that, you do that all the time. Like there's no adrenaline kicking in, right? Because it's just, oh, this guy thinks he knows something. All right, let's go. So you don't get that same adrenaline pump. So now you hit him 5 times and he doesn't go down because he's jacked up on adrenaline. He hits you with one good shot. You might actually be in trouble. So there's pros and cons to not having fear versus having fear. So for somebody that has an anxiety disorder, though, and I'm going to use my mom as an example. Sorry, Mom, love you to death, but I think she probably has an anxiety disorder. I remember one time asking, could we run up to the mall? And I wasn't a kid anymore. I was grown, and I was like, hey, you want to run up to the mall real quick and get? I think we were clothes shopping for my kids for school or something like that. And she's like, oh, I don't like going to the mall. And I was thinking, like, why? Because it's too much walking, or why? And she's like, no, I just don't. I don't want to get my car broken into. I'm like, at the mall, Willowbrook Mall, right? Not a terrible mall, not a terrible part of town. And I'm like, why? Why do you say that? Oh, I read on the news that they've had several cars broken into, and it was like Christmas time. And I'm like, okay, first of all, the parking lot at the mall has literally thousands of cars. So it would make sense that during Christmas, people go shopping. They don't want to carry the bags around. They go put them in their car. They're in plain view. Maybe they left the car unlocked. Maybe they don't have tinted windows. A thief maybe saw them put it in there. They're going to jump on that opportunity. But that's no reason to just say, I'm never going to go to the mall again, ever, right? Do you know statistically what the odds are of your car that does have tinted windows being broken into? And by the way, there's nothing inside your car that anybody would break in and steal, right? We're going to go in, we're going to carry our bags, buy whatever, and then we'll leave. So while we're in there and your car is empty of valuables with an alarm and locked and everything else, you're saying that that's the reason that you won't go to the mall? And that is absolutely, we could not talk her into going to the mall. And it was like, because there's no talking sense into somebody that feels that level of anxiety, that level of fear, and they realize that it's exaggerated, but it doesn't make the feeling go away. You can explain it with statistics and numbers and all that stuff all day long, but it's not going to make that feeling go away. So they're going to stick to their guns, and they're going to either do or not do whatever they need to do or not do in order to not feel that feeling anymore. So it can be very sort of frustrating as a clinician to point out all of the reasons why, and they just immediately get shot down. 30% of Americans will experience one or more anxiety disorder in their lifetime. That's a lot. It's 1 out of 3 people, right? Some people do appear to have a genetic predisposition. Okay, let's go past this. Very likely to be comorbid with depression. Again, as you can imagine, living with this constant fear sucks, right? Lowers your quality of life, brings you down into that realm of clinical depression. So that just makes perfect sense to me. It's different across genders and ethnicity. Nobody really fully understands why, as you would maybe expect. Women are more affected than men. Uh, Women are definitely more in touch with their emotions, in my opinion, than men are. Men are more sort of acculturated to, shove them in a box somewhere in your brain and close it off and soldier on. So women are less so motivated to do that. So that kind of makes sense to me. Whites are affected more than blacks or Hispanics. Um, Highly reactive babies tend to be more prone to anxiety later in life. So we talked about temperament back in the developmental chapter. Personality does sort of set around your 20s. Doesn't change too much. It's certainly not set when you're 3 or 4, but there's research that shows highly reactive babies or highly anxious babies tend to be they don't really outgrow it. A lot of times it stays that way. Anxiety disorders do not impair a person's ability to think realistically. So again, I can explain to my mom realistically what your chances of your car being broken into, and she understands that. She really does. But then if I forced her to go to the mall, the entire time we would be there, I already know she'd be checking her watch. She'd be rushing through. No, I don't see anything in the store. Let's just go. Because that fear is just a weight on her shoulders that she just could not shed. And so, over 40 years or so, nobody really tries. Everybody just lets her kind of carry her anxiety. Again, lots of sympathy for people that suffer from things like this. Anxiolytics can be very effective for treatment, as well as a number of therapeutic treatment modalities. So this is the part where I talk a little bit about drugs and therapy. Is it necessary to have both? Which is better, one or the other? And my answer to all of that is, well, it depends. People can be depressed for lots of different reasons. People can have a tough run in life, much like what I'm probably experiencing now, right? I mean, I've been divorced for, 7 years. Certainly over the marriage, going the direction that it went, that was never the issue. But getting back on your feet after a divorce financially is much more difficult than I ever expected. I sort of forgot that I would be handicapped with 50% of all my checks going to child support and 15% going to student loans, and then of course taxes, and then oh yeah, by the way, there's like nothing left. You're like, holy crap, I have to make 6 figures in order just to have a 1-bedroom apartment. I mean, it's insane. So yeah, it's a little depressing, right? But do I have clinical depression? Well, it's possible if I have enough of that criteria met, right? It is possible, but would medication help me? Not really. I mean, I would argue not really. Others would argue, yeah, I might take the edge off, right? It's not going to make me happy. I'm not going to take these meds and feel great, right? I'm going to take these meds, and like I said, it just maybe takes the edge off a little bit because my depression is centered around situational factors. Now, there are lots of people, and in my brief time doing therapy, I encountered most of these people because I was in a very affluent part of town. So everybody that came they were easily able to afford $100 an hour fee for therapy, and they're driving Range Rovers and they're living in mansions, and they don't even work. Their husband works, but he's an airline pilot, so he makes $150,000, $200,000 a year, but he's still relatively present. I mean, he's not one of those people that's never home. Husband that works, makes good money, but is still around. You can go on vacations. You think, man, you got the perfect life, and they're depressed. Does that person benefit from medication? Often, in my experience, they benefit more because it's not it is a little bit their thinking, right? The maladaptive thinking that through therapy can be pointed out. You can put tools in their toolbox to sort of combat that, to identify that, and to be able to combat that. So yes, therapy works wonders, but oftentimes those people have a chemical imbalance, and that is the reason for their sadness, their prolonged feeling of hopelessness and helplessness and low self-worth and all that kind of thing. So those antidepressants lift them up to a normal level, and then the therapy helps they work in conjunction with each other. So yes, the boiled down answer is this. Sometimes meds do a lot of good, and sometimes they just do a little bit of good. Sometimes therapy does a lot of good, sometimes just moderately so. Putting them both together often makes each of them better. But it just depends. It's very individualistic. It depends on the disorder, and it depends on the individual. So there is no across the board answer for that. But largely speaking, there are certain medications that can be very effective for lowering people's overall level of anxiety. I know when I got LASIK done like 5 or 6 years ago, and when I got it done, they gave me a Valium before, because I had mentioned that I have kind of a thing about I don't like things close to my eyes. I don't know why. I've always just had a weird thing. Like I could never wear contacts. There's no way I could touch my eyeball. And my kids were little, and I'd have them. They'd have their hands, and I'd be like, I'd always no, don't put your hand anywhere near, because I didn't want to get accidentally poked in the eye. It was the weirdest thing. But I mean, nobody likes having their eyes poked. But I had like a phobia about it almost. And here I am going to do LASIK. So that was a little bit nerve wracking. But I hated wearing glasses enough that I thought this is going to be worth it. I don't care. Do whatever. Cut my eyeballs out. Put them back in. I don't care what you got to do. So because I had mentioned it, they gave me a Valium, which is the only time I've ever taken it. Oh my God, it was great. I went in there and I'm like, all right, cool. And I'm laying there and they got my eye pinned open, right? And they hit the laser and they tell me what I can be expecting, and I see the light and all that. And they had told me that they actually cut the around your eye, and then they flap it up, right? Whatever that skin is, they flap up, and then they shoot the laser in, and then they flap that skin back down over on your actual eyeball. I knew that was happening. Didn't care. I was totally cool with it, right? And then I smelled this smell, and they didn't tell me about this. And I was like, what is that horrible smell? That machine that you're using stinks. And then I realized that is the smell of the flesh of my eyeball burning from the laser, right? That's what the laser is doing. It's burning away flesh, and it's reshaping your retina. And I was like, oh, that's my burning eyeball that I'm smelling. Cool. That's how good Valium is, right? So I've only taken it once, and it was for medical reasons. But if anybody has any, let me know. It's good stuff. All right. Separation anxiety disorder. Developmentally, okay, this is important too. And this is like being a lawyer, by the way. If anybody's interested in law, right? Like one word in a definition can completely change the whole thing. There's a well-known case in Dallas where this officer went to a call, and husband and wife had been into an argument, and he shoved her, like just pushed her back, and she kind of sat down on the bed or whatever, and she called the police. And they told the story about exactly what happened, and they both their stories matched and everything. And the officer said, well, what do you want done? And she was like, I just want him to go stay at his mom's tonight. And he was like, are you willing to do that? And the guy was like, yeah, it's fine, whatever. And so officer left, the suspect left first, and then as soon as the officer left, suspect came back and killed the wife. And it was a big deal because they were saying the officer should be fired and brought up on, insubordination, dereliction of duty and all that kind of stuff, because he didn't make the arrest. And then all these other officers kept stepping in and going, well, that's what everybody wanted. That's what he wanted to do. That's what she wanted to do. There were no injuries. It wasn't a particularly violent thing. She was getting in his face, and he kind of pushed her back, and just because the bed was right there, it's not like he shoved her down a flight of stairs, right? So y'all are blowing this out of proportion. But when it came down to it, they looked into the Code of Criminal Procedure, and what it says, only for this law, it specifically says, when an officer is made aware that a family violence offense has occurred, he shall make an arrest in order to prevent future family violence. That sentence made that officer lose his job and get brought up on charges because of the word shall. It didn't say the officer can make an arrest or the officer has grounds to make an arrest. In other words, he has discretion, right? In this case, this is what he used, was discretion, and not even terrible discretion at that, I don't think. But in this one particular statistical outlier case, this guy who hadn't exhibited any history of violence other than this, quasi-violent shove, came back and went the extreme. So that word shall made all the difference, right? That's what happens in these criteria, right? So developmentally inappropriate and excessive fear, or, that word or is important, or anxiety concerning separation from those to whom the individual is attached, usually mom, but not always, and is evidenced by three of the following. By the way, let me stop right here and say this. For the love of God, do not try to memorize these 8 criteria, because if you want to go forward and look, right, I'm going to give you all the criteria for, actually, God, where are they? Like there's 9 criteria for depression. I don't want you to try to memorize these criteria. These are taken out of the DSM. They're condensed. They're short enough to fit on a slide, but long enough to get the gist of all that's that particular criteria. You don't need to know how many there are, or it's 3 of 8, or what the 8 are. Please don't try to memorize any of that. I'm giving you a lot more information here than you're going to ever need on the exam. So, the exam questions are going to be, little Johnny cries when his mom leaves the room. He might have what? Separation anxiety disorder, depression. They're going to be those kind of questions. So it's going to be very, very broad scenarios. And if you know kind of the basic notion of what is depression, what is anxiety, what is separation anxiety disorder, you'll be able to identify the scenario. So, all right, so back to this. So 3 of the following 8, anticipating or experiencing actual separation from home or attachment figure, worry about losing attachment. Okay, before I read these, let's get real for just 1 second. So when I divorced, my kids were 3 and 5, and their mother was a first grade teacher at the school that both of them were elementary school students at. Divorces are never pretty. They're never good for the kids. Sometimes it's a better alternative than staying together and continuously fighting or things like that. So, it is sometimes a necessary evil, and in my case, I felt like it was. So, did what I did. Now, after I got divorced, I don't like being single, so I started dating right away, and connected with somebody, and she happened to have 2 kids that were the same age as my kids, literally exactly, like they were both a month apart from my kids' birthdays. So my ex did not take the divorce very well, and she started telling my 3 and 5-year-olds, and understand my 5-year-old was much smarter than an average 5-year-old, so he was really on the mental. Emotionally, he was very much 5. Intellectually, he was more like 8 or 9, right? So he's able to connect dots and put things together in a way that you might not expect a 5-year-old. But then again, he's emotionally, developmentally appropriate. So he doesn't get it, right? So she started saying things like, well, your dad, by the way, it was very mutual, right? I moved out. She agreed. She's the one that went and filed. I wrote our divorce decree. She accepted it. She went to court and filed it. I mean, it was very mutual. We both wanted out. But for some reason, because I started dating, she started telling the kids that, well, your daddy doesn't love us anymore. He doesn't want us. Yeah, he found somebody else. He has a new family now. Yeah. He's got his own kids now. Yeah, those are his kids. So, that's just a scorned woman being a scorned woman. Not to make excuses for her, because she's awful and she'll burn for those things. But anyways, so my son, 5 years old, developed super bad separation anxiety. It was so bad that even though she was a teacher in his school and was right down the hall from where his class was, he would panic and run out of the classroom and have to see her. They had to move his desk to the doorway and move her class to the adjacent classroom so he could literally sit in the doorway and look over here and see his teacher and look over here and see his mom teaching her class. Well, I was totally unaware of any of this, by the way. None of this was relayed to me for a while, but once it was, through court-ordered counseling that he got, I was able to ascertain sort of where it came from, because she was not telling the truth to the therapist. So what we found out is those comments that had been made, and that what my son's thinking was because this is what he was fed, is, wait a minute, well, if dad just decided one day he wanted to walk out and leave, what's to stop mom from doing that tomorrow? Mom could just wake up and go, yeah, I want to leave, and then I'll have nobody. We will literally have no parents, because both of them just decided to leave. So that was the reasoning for his, I need to keep eyes on you all the time because I don't want you to leave. So anticipating or experiencing actual separation from home or an attachment figure, which in this case was her, yeah, he lost his mind. Worrying about losing them, constant worried. Like, he stopped watching TV, stopped playing with toys. It was just clinging to mom constantly. Worrying about events that may cause separation. He would worry about her getting kidnapped. He would worry about her getting lost. He would worry about her, deciding that she wanted to leave. Reluctance or refusal to go out. Yes. Reluctance to being alone. Yes. He had been in his own bed since he was like just barely 3. And at 5.5 years old, he was back to sleeping in her bed with her every night for like over a year. Would not sleep in his own bed. Wouldn't sleep alone. Nightmares, yes. Complaints of physical symptoms. That one I don't know. I don't know if he had that or not. But yeah, he met 7 of 8 for sure. So very, very severe separation anxiety disorder. Now, here's why I'm telling you this whole story. The prevalence rate for separation anxiety disorder is less than 1%. Let's just call this 1%. And let's just call this 2%. So between 1 and 2% of adults, 4% in children. The most prevalent anxiety disorder in children under 12. This particular disorder, if you look, it'll tell you that it is developmentally appropriate between the ages of about 16 months to about 24 months, I think. So if you come to me and you tell me that your kid does all of these things, right? As a matter of fact, we had a house guest last weekend, and she has a 2-year-old, and her 2-year-old is being raised by a single mom who lives with her mom. So she's got a mom and a grandmother in her daily life, right? She's 2, so she's not in school yet. So this is her whole world, is mom and grandma. And her dad pops in, once a month maybe, and spends time with her. But apparently she's going through terrible twos, so she's, kind of feisty. And he had to get on to her. Now, I don't know what happened. Nobody was there. Nobody knows. But he yelled at her. He spanked her. He did maybe both, maybe one or the other. I don't know. But she is terrified of men. She's never been that way before. I have held her and played with her, and she's loved it and laughed and giggled and everything. Every time I walked in the room, she lost her mind. Ran to mom, held onto her leg, wouldn't look at me, wouldn't talk to me. It took me the entire weekend to finally kind of break through that. Unfortunately, I was able to. And by the last day, we were pals again. But it was so bad that it actually ran her boyfriend off. Because her boyfriend was like, I can't even be in the room with you because you can't be in a room without your daughter, and your daughter can't be in the room with me. So, I'm not going to deal with this anymore. I'm out. So, huge big deal. Now, is her kid diagnosable separation anxiety disorder? No. And the reason that kid is not is because if you look in the book, right, it says, and it's not on the slide, but it says from 16 to 24 months, it's developmentally appropriate. Her kid's 24 months, which means this is normal behavior, okay? This is just something 2-year-olds go through, right? They're attached to mom. They recognize their necessary, the necessity of mom to provide for them. They're cognitively aware of that for the first time, and they don't want to lose her. So that's a normal part of growing up. But then they get a little older and they realize, she's not going anywhere. She can leave the room and she'll just come back in a few minutes, right? So they grow out of it. So again, if you bring a 5-year-old, almost 6-year-old, like in my case, it would not be developmentally appropriate for that child to have that many criteria met at that age. So I'm going to trip you up on the test if you haven't seen this and you haven't had this broken down for you in that fashion. And I'm going to say, little Johnny is 4 years old and he does this, and I'll list 4 of those. Does he have a clinical diagnosis of separation anxiety disorder? And the answer is no, yes, because it is not developmentally appropriate for a 4-year-old versus this kid who maybe it would be developmentally appropriate for, right? Okay, so again, little pieces of this make a huge difference. That's why I'm telling you, don't try to think, oh yeah, my kid's got that, or this kid's got that, or whatever, because I promise there's something in here that you might not be picking up on that's important, okay? So, generalized anxiety disorder. This is characterized by excessive anxiety and worry that's not correlated with particular objects or situation, persistent for at least 6 months. So this, you'll see this a lot, and most of the time, that's the time frame, is at least 6 months. Not always. Sometimes it's 2 weeks. So again, we talked about in the definition that in order for it to be qualify as a diagnosis, it has to be persistent for a certain amount of time. And in this case, for this particular disorder, it's 6 months. So here's kind of an example of the different perspectives of where this general fear, right, this general anxiety comes from. Biological explanation include things like the prefrontal cortex overcompensates messages from the amygdala. So the amygdala is the fear processor in your brain, right? So basically your amygdala is sending, fearful thoughts basically to your prefrontal cortex, which then overinterprets them, okay? Increased GABA neurotransmitters, a particular neurotransmitter that's in too high of abundance. Heightened automatic nervous system activity. So again, there'll be a ton of different biological explanations from that perspective because that's what they do, right? And all this is backed with certain research, right? So it might be correlational. Maybe there was a correlation between these two things, but can we say that it's a cause? No, remember, correlation does not imply causation. So maybe there's some correlational evidence there, but it lacks like full causal reasoning behind it. So these are some biological explanations, but then you have your cognitive explanations, who say that very nearly all schemas are associated with worry or threat. So remember when we talked about schemas, we had all those different, index cards, like for dog, and it said 4 feet and, furry and has a tail, right? Whatever's on your schema, whatever you know about that particular thing. Well, on that one, it would also say they bite, they run faster than humans, and they're stronger than humans, right? And then we look at the one for cat, and it says they bite and they scratch. And then we look at one for bats, and we say they carry rabies. So it's like some people are just wired to know what the danger is in everything. And so everything they learn about, whether it's a dog or a puppy dog or a kitty cat or, something like that, or a bat, which is not particularly common around here, right? Not that we see them in our backyard or anything. But we know they carry rabies, right? So it's for whatever reason, everything they learn about, there is a fear component that's kind of attached to it. So what happens is everything has something to be afraid of, right? So that's the cognitive explanation. Social explanation studies show strong correlations between high anxiety and low socioeconomic status. And I know because I'm poor for the first time in my life. It sucks to be poor, right? That whole money can't buy happiness crap, definitely said by a rich guy. I love that song by Chris Jansen. He says, well, money can't buy happiness, but it can buy me a boat. And that's definitely true. Have you ever seen a sad person on a boat? No, right? It's like impossible to be sad on a boat. So yeah, money definitely comes into play. Disruptions in social connectivity due to divorce, separation, death of a spouse, loss of a job. So issues, right, that happen. And sometimes you can be affected by issues that happen to other people, right? My parents bicker and fight, and it bothers me. I hate, they're my parents, and I want the best for them, and I want them to be happy, especially they're both retired and, under the same roof, and, they're financially set, and, at least my mom's health is good. So, they probably have a little while left, hopefully a long while left. And it sucks that their quality of life is as bad as it is because they don't get along and they can't communicate effectively. And it affects me, and it causes me anxiety because I worry about them. So it's not just things that are in your life, it's those people that are in your circles that are close to you. So an integrated perspective would take bits and pieces from all of this. Individuals who are already predisposed, biological, who might have maladaptive thinking processes, cognitive, and experienced recent situational stressors might be prone to generalized anxiety disorder. So you see in this one sentence, they took pieces of all three of these and they incorporated them all into one sort of dynamic explanation that encompasses multiple perspectives. So it's really and some of them, I will tell you, some of these disorders lean very heavily on the biological side. There are tons of studies that sort of provide evidence for a biological etiology. Then there are others that are, I think, very much cognitive. So they're not all like 30%, 30%, 30%, 10%. It's all different percentiles of different explanations. So it just depends on what we're talking about. All right, moving along to other disorders. Panic disorder. A panic attack is the experience of intense fear and automatic arousal in the absence of a real threat. So that is different than, I'm a police officer responding to a domestic violence call, and right as I get to the door, I hear gunshots. Well, what do? Well, you draw and you go in most of the time, right? I mean, you could retreat and hold a perimeter and call TAC and all that, but most of us are going to draw and we're going to go in, right? Is that going to produce an intense fear? You're probably not going to admit it, but yeah. Is it going to cause an automatic arousal, right? Physiologically? Yeah, right? So, but is that a panic attack? No, because in the absence of a real threat. So if I'm going to a domestic violence call and I hear a gunfire, there is a real threat, right? It is a normal reaction to have that fear and arousal going into that situation, all right? But a panic attack is when you feel those same feelings, but you look around and there is no real threat to be found, right? It's worrying about something that maybe could happen. It's the idea that, if I'm thinking about walking to get the mail and I have a neighbor a couple of doors down that has these real big bushes in his front yard, right? I have to, if I'm walking down the sidewalk, right, I have to walk right by that bush. And if I'm sitting here and I'm thinking I need to go get the mail, and I start picturing that walk, and I picture that bush, and I picture somebody jumping out and grabbing me and holding me down on the ground, and I'm trying to scream and yell, but they're covering my mouth. And the next thing you know, it's like I'm in that attack, and my heart starts going crazy. I start sweating. I'm breathing fast. I'm short of breath. I have all these things that are going on, but I'm still sitting in my house with the door locked, and I haven't gone anywhere. There is no real threat. That's a panic attack. Typical duration is about 10 minutes. If you have these repeatedly, people that have a lot of anxiety sometimes will experience multiple panic attacks. There is something called panic disorder. Repeated attacks and fear that you're going to have another panic attack, right? Once you have one, you're like, holy crap, that sucked. I don't ever want to go through that again. But then you're kind of always afraid you're going to have that again. I've never had one of these, but the closest thing that I can relate is I had one migraine one time in my life. It was so weird. Normal day at work, I was coming home from work, and I just started feeling terrible. My head just felt like, I thought I was having a stroke, and I pulled over and I threw up because I was so nauseous that I hurt so bad, and I just, I'm a guy, so I didn't call anybody or whatever. I just laid back in the car and kind of, waited it out, and it took a while, and I limped my way home, and the next day I was fine. And I never went to the doctor, never got checked out, but I'm pretty sure it was just a migraine. And oh my God, if I wasn't just worried that I was going to have that again, because it was debilitating. It was horrible. So, I got this migraine, Tylenol, and kept it in my car, and anytime I travel, I always had a little pill bottle thing of, travel thing of migraine headaches or whatever. Years passed. Still, always had it in my car, always had it in my travel bag because I was so afraid that I would have that again, and, I think I was doing police work at the time, and it's like, what if I was in the middle of a call? What if I was in the middle of a shift and then I had that? What if I was on an extra job where I'm going to be there for 8 hours and halfway through I just get this debilitating headache and now whatever. So, that must be kind of what it's like to live with this constant fear that it's going to happen again. All right, so a term called differential diagnosis. A differential diagnosis is because sometimes like panic attack or panic disorder and generalized anxiety disorder and anxiety disorder, they have a lot of symptoms that overlap. They sound very, very similar, right? So you have to do what's called a differential diagnosis, and that's where you look at the criteria and you say, does it meet all of this? Yes, it does. Okay. Does it meet all the criteria for this one? No, it doesn't. Why? Well, because, like for instance, in this example, generalized anxiety disorder is non-specific threats. That's where the name comes from. Just general. Just could be anything. It could be finances. Could be being attacked. It could be getting sick. It could be losing a loved one that's not sick. It could be losing your job that's in, you're in good standing at. So it can just come from any direction. You never know where it's going to come from. Panic attacks are in regards to an immediate and usually present threat. I don't like the way that's worded. Not usually present, because up here it's saying in the absence of a real threat. So that's a little, I don't know, I'm not sure why I worded that way. So ignore that. It's not usually present. It's perceived, usually perceived threat. Let's call it that. Maybe that's what I was trying to say there. So sorry about that. I hope that's not too confusing. So again, I'm going to do a differential diagnosis, and I'm going to say, you're going to tell me about your panic attacks, your anxiety, and I'm going to say it's very specific to one thing. So I don't think it's going to be generalized anxiety. I think it's not generalized. It's very specific. So a differential diagnosis breaks down those criteria, and it rules one thing out while accepting something else. Okay, that's called the differential diagnosis. Many people will experience one or a few of these in their life. 2.7% of the population are affected as a disorder, more prevalent in women, as you might have expected. More than 50% have comorbid anxiety and or depression disorders. So more than half the people that have this, because again, imagine living like that, right? It would suck. So you're probably going to be pretty depressed. It's going to wear you down, or you're going to have tons of anxiety about your panic attacks. So again, this just makes perfect sense that you would have a high comorbidity with depression and or anxiety. Usually begins in adolescence and early adulthood. Symptoms include shortness of breath, sweating, trembling, nausea, dizziness, fainting, rapid heart rate, feelings of terror, all the things that you would expect. Some people live that and it's horrible, and other people pay $12 to go see a movie to produce all of those same feelings. Go figure. All right. I'm gonna go through this, right? So I'm not gonna read it, but again, I'm gonna give you some biological explanations, some social explanations, and then an integrated approach. You can read that on your own. Moving on to phobias. A phobia is an unrealistic fear of an object or a situation. And again, the big word takeaway here is unrealistic fear. If you had a fear of rattlesnakes, and you lived in, where we live, or copperheads, is that an unrealistic fear? Well, no. It's a poisonous snake that is faster than you, and if you surprise one, it will bite you before you even know that it's there, and you will have some serious medical consequences because of that. So that's not an unrealistic fear to say that you're afraid of rattlesnakes. Now, are you afraid of polar bears? Okay. Is it unrealistic to be afraid of polar bears? Well, if you're an Eskimo, right, and not to, this isn't a microaggression. I had to read about microaggressions from college. God, I hate the world that we live in. So I'm not a slight against Eskimos, right? But if you lived in Alaska and you had a fear of polar bears, would that be acceptable? Yeah, probably. I don't know. I'm guessing that they exist there. I don't know. And they're big and they're strong and they're scary and they could probably kill a human pretty easily. I don't know if they would, because they just usually sit around next to an igloo drinking Coca-Cola, right? With Santa scarves and all that. But yeah, if I here in Houston was afraid to go get the mail because I don't want a polar bear to come out, right? That phobia would be weird. If I went to the zoo and I saw a polar bear behind glass and I freaked out and ran away, that would be a phobia, because it is unrealistic to have that kind of a fear, right? Or the situation. Situation being, I'm at the zoo, right? I'm perfectly protected. Thousands of people a day come through here and nobody's ever gotten hurt. Why would I get hurt, right? So this is, again, where the interpretation comes in. Is it realistic or not? What is the situation? Does it qualify as a phobia or not? Kind of depends on the totality of circumstances. Criteria includes consistency of response, the object that's actively avoided, whether the fear is unrealistic, whether it's persistent for 6 months or more. Again, there's that time limit. And does it cause distress? So, I don't particularly like bugs. That's weird, big guy, and I'll leave the room if there's a roach, right? Because I just have this kind of fear that I'm going to go to step on it and it's going to fly up and get on me. In my mind, every bug can fly, and they're all faster than me. And so I don't want to try to step on it because, again, I don't want to fly up my pant leg while I'm trying to step on it. So, yeah, I just leave and don't go in that room and call the exterminator the next day and let them come out and spray and kill everything. Is it a phobia? No. I mean, I've had a bug crawl on me, especially if I'm outdoors or something. They're all over you. You're just like, hey, smack it away, and that's it, right? So I don't not go outside because of fear. I don't, see one and burn my house down or anything like that, right? So it's a dislike, but it's not a phobia. All right, so the new DSM, and I don't know why I went to the trouble of giving you all these numbers that you don't need, but they broke into a code, and it's interesting. They have animal phobias, and that's any kind of animal. So spiders, even though it's not technically an animal, right? That falls into that, right? So spiders, insects, dogs, some of the most common ones. The next one is natural environments. So fear of heights, fear of storms, fear of water, all of that is natural environment. So it would fall under this 0.228. There's a lot of phobias that have to do with blood, injection, or injuries. So that has its own code. And then there's situational phobias, like airplanes or elevators, things like that. And then there's others. Clowns is a very big one. Pickles is on there. So there's a video. I'm pretty sure I included it on the video link. It's an old clip from the Maury Povich show. I don't know if that's still a thing, but pretty popular for a while. So we had this girl on there, and she has a phobia of pickles. And the entire time that she's explaining it and everything, the crowd is just laughing, and they keep cutting to the crowd. Everybody's laughing at her. And I got to tell you, I've seen a lot of people fake things, malinger symptoms of things. And I've seen people on talk shows. I actually knew, it was like a friend of a friend. They lied their way onto a talk show under false pretenses or whatever. It was a couple, and they lied about something that was going on so they could be on a talk show because they wanted a free trip to New York and a per diem for a day and a half, and then to be on TV and all that. And they totally, malingered their way onto the show, basically. So I've seen that, but even when I was watching it, I was like, man, if I was at home and I didn't know, I think I would be able to read these people are full of crap, right? I don't think this pickle phobia chick is lying. I think it's a real, actual phobia. She is terrified of pickles. And they ask her, like, what does she not like about it? And she's like, I don't like anything. The shape, the bumps that it has on it, just everything on a pickle is just gross. They're just disgusting. So what do? They send her to a pickle farm, and they try to get her to, like, touch a pickle. And there's literally, they're processing pickles everywhere. So it's the whole assembly line of pickles, right? And they bring a platter out, and she's supposed to touch one. And she can't do it. She screams and runs away, and she collapses, and she's screaming and crying and freaking out. So years later, all right, so it's a good clip. You should check the clip out. And then there's another person that's got that same fear of mustard. So they go crazy about the sight or smell of mustard. So is it possible to have that level of a fear about an inanimate object that obviously means you no harm? I mean, you had statistics and you said, how many people died last year from pickles? Well, out of 200 million people in America, the answer to that is zero. Zero number of people died from a pickle. How many people got hurt from a pickle? Zero. How many people got sick from a pickle? Yeah, none there either. So you put that in their face and you go, okay, how do you argue with those numbers? Do you think you're going to be the first person in history to be murdered by a pickle? So where does that come from? Well, remember back to Freud? This is why I like Freud. So psychotherapist watches the show and says, there's something to that. That girl's not lying. So
offers to help her for free. Obviously, she doesn't want to live this way, right, with this fear. So she agrees. So they get to talking and doing counseling together, and it turns out in psychotherapy, she starts to kind of dig back into her childhood, and she had, I want to say it was a stepfather. I think it was a stepfather. She was very, very young, like 5, and he was a pedophile, and he wanted to do inappropriate things with her, as pedophiles do. But he was also a real crime junkie, so he watched all those shows about crime stuff or whatever, and he was very fearful of DNA, and so he did not want to actually penetrate her with his own parts because of DNA. He didn't want skin cells or semen or whatever to leave his body into hers, and then it can be detected on a rape kit, so he's busted. So he chose to sexually assault her with a pickle, and he would do this pretty often, and she was told to just be quiet and don't tell anybody, and so she repressed these memories. So the sight of a pickle is somehow tapped into these repressed memories of this horrible thing that happened to her, but without bringing it up to a conscious level where she can interpret that fear. So the fear was real. It was based on something that she very much should have been afraid of, the pickle guy, but wasn't able to retrieve that into consciousness because her ego was protecting her from remembering that horrible trauma that had occurred. So anyway, so she recovered these memories, and I don't know what the ending of that story was. So I watch this and I see all these people in the audience that are laughing at her for being terrified of a pickle, and it's hard not to. I think I probably did a little. The absurdity of it is kind of hard not to kind of smile out of just sheer morbid, human reaction to something that's odd. But again, I believed her from day one. I really thought that nobody could act that well, and turns out that that's where most phobias tend to stem from, is some perceived or actual trauma that has occurred in that person's history. And when you dig through and find it, it makes a lot of sense why somebody would have an unrealistic fear, because they have not processed that trauma properly. I know when I was in daycare, and I tried to track down this memory, like age-wise, and I guess my mom said I only did daycare for a brief while when I was about 4. And I remember one time when she was driving me to kinder care, and we were driving across there was like this big field to the right, and it was still kind of dark outside. It was really, really early. And I looked down, and I just happened to be looking across the field, and lightning struck. And I didn't understand distance and perception and how lightning worked, so I thought it happened right next to the car. And I was terrified. I thought we almost got struck by lightning. And it turns out it was just off in the distance, like lightning normally is, right? Probably miles away. But I was a little kid, and I didn't know any better. And I remember that day, they had to call my mom to come and get me because I was just scared in the corner the whole day. And I actually still remember being terrified for some reason. Just thought it was a near-death experience, right? And, I told my mom what happened, and she just kind of laughed and explained that, oh, no, that's super far away. And, I guess I got over it. But, that's the kind of thing. What if I didn't communicate it? What if nobody did pick up on it? What if I just held that fear and it wasn't talked about? It wasn't explained to me. And next thing you know, every time there's a lightning and thunder, I'm running and diving under the bed, which a lot of kids do. But I didn't, because I had that experience. It was explained to me, and I moved past it. So so phobias are something that are easy to laugh at, but they're very real for the person experiencing it. All right, social anxiety disorder, an unrealistic fear of being scrutinized and criticized by others. Examples are social interactions, like having to introduce yourself, being observed in social settings, just basically being seen, right? People are going to think that you look funny, or you're afraid you got a stain on your shirt, or maybe you do have like a little spot and you're afraid everybody's going to notice it. Um, I remember I had a job interview one time, and I had a white shirt with a tie and all that whole thing, but I only had one white shirt, button-up shirt, and I didn't realize it till the day of, or I would have tossed it and bought a new shirt. But the collar was kind of sweat stained. It was kind of, it turns that ugly brown color, and it was kind of up over the collar just a little bit. When I got dressed, I noticed it, and the whole interview was terrible because all I could think of is they probably see this old sweat stained shirt and they're like, ugh, this guy's gross. Does he not shower? Or can he not afford to buy another shirt? Ugh. And they probably never even noticed it. Or if they noticed it, they probably went, oh, he's got a stain there. Anyway. And it was probably that big of a deal to them. But when you're in the other side of the table in an interview, you think everything's about you and everything is being noticed. And so, is there a real fear that you're going to be scrutinized by others? Well, sure, that happens in social settings. Even criticized by others. Sometimes outwardly, sometimes they just keep it to themselves. But we're all making judgments every time we listen. Y'all are making judgments about me while you're watching these videos. Yeah, it exists, but again, is it an unrealistic fear? Does that fear keep me from being able to do that thing? Not everybody likes social speaking, right? No, not everybody can stand in front of a classroom and speak without and staring at their feet the whole time, right? It takes practice. But if you literally can't do it, if you had to do it for my class and you said, nope, not doing that, and I said, well, I'm sorry, I'll have to fail you, and you went, okay, I'll take the F, you might have social anxiety disorder. If you said, oh, I really don't want to do that, and I said, well, it's part of the class, sorry, and you're like, oh, God, I'm going to suck at this, and then you got up there and you did suck at it, you probably don't have social anxiety disorder because you got up there. You did it. Again, not everybody is good at it. Not everybody can do it, without fear. But there is sort of a realistic fear of being scrutinized and criticized. So if your fear is prevalent, that's not conducive of a diagnosis. If your fear is unrealistic and it prevents you, it causes you distress, that's different. So that's social anxiety. All right, I mentioned this one earlier. This is agoraphobia, fear of open spaces. It actually comes from the Greek word agora, which means marketplace. So really, it's fear of two or more of the following. Using public transportation, let me tell you right now, I don't want to use public transportation. Have you seen who rides Metro? I don't want to be on those buses. Not in Houston anyway. Now you go to Washington, D.C., tons of people use public transport. People in three-piece, $3,000 suits are on public transportation. Obviously, New York, that's the most common way to get around is on the subway. You go to Chicago, you ride the L, and that's public transportation. There are certain cities that are very good with public transportation. Houston, not really so much one of them. So, again, that fear of being on public transportation, is there a legitimacy behind that fear? Depends. Being in open spaces, being in enclosed spaces, standing in or being around crowds, or being outside the home. The number one thing that you're going to hear ever associated with agoraphobia is this last one, being outside the home alone. People that have agoraphobia just don't want to leave their homes. Okay, all this other stuff, I've never even heard of that until I looked at the DSM and saw that. I was like, what? Never heard of somebody saying, oh, I'm afraid of open spaces, I have agoraphobia. It's there. It's super rare. Okay, this being outside the home, not very rare. I would say, if I had to make up a number, 95% of people that have agoraphobia have this one, right? They might have some of these other ones, but they definitely have this being outside the home. Prevalence rate is roughly 2% for adults. Females are twice as likely as males to be diagnosed, which makes sense. Females are much more likely to be victimized from everything from robberies to sexual assaults and everything in between. So that makes sense that there might be a little bit more fear there. Again, not particularly unrealistic that they would be more fearful, but we have to kind of gauge that level of fear versus the situation. All right, OCD, one of my favorite ones to talk about. In the new DSM-5, this was given its own classification. So obsessive compulsive disorder is now its own category. Okay, they've expanded the number of categories. So it used to be anxiety disorders, and you had generalized anxiety disorder, and agoraphobia, and phobia, and you had your specific disorder, you had all these different kinds of anxiety disorder, and OCD was one of them. Okay, it's grown past that. It's bigger than that now. So now OCD is its own thing. So it's made up of two things, and this is important that you understand the difference between these two things: obsessions and compulsions. That's the name of the disorder, obsessive compulsive disorder. So breaking that down, an obsession is an intrusive, distressing thought. We've all been obsessed by something at some point, right? So, and I say that, with a grain of salt, obsession, colloquially speaking versus clinically speaking. So if you can see, I have a little bit of an obsession with Captain America, right? You can't even, that's not even a tenth of my collection. That's just the more expensive ones, right? That big one that you can see in the top left, that's custom made. That was over $100. The one on the very top, you can't really see that, but it's also custom made. It was carved out of barracuda bone where was I? I think it was in the Yucatan whenever I got that. So yeah, I spend stupid money on stupid, things. It's an obsession. But it's a colloquially used term, obsession, like an extreme love. Let's call it that, right? But from a clinical perspective, obsession has a very specific definition. It is an intrusive, distressing thought. Intrusive meaning, there's the bad part, right? It's intrusive. I can't get it to go away, right? That's what intrusive means, right? It comes in uninvited, unwanted, right? I like Captain America. I like shopping at different toy stores and seeing if I can find a toy that I don't already own. I like looking at, handmade, homemade Captain America merch that I can add to my collection of stuff. I have everything. I have Pez dispensers and Lego blockheads and pop figures, and that one's gold inlaid, and that one's made of wood. I got all. It's an obsession, but it's invited. It's not inviting itself. It's not that I'm at work and I can't stop thinking about Captain America. It's not like that, right? So it's two uses of the same word, right? Obsession, again, used in everyday language, it sort of minimalizes what that truly is, all right? From an OCD, from a clinical perspective, an obsession is intrusive, and it causes distress because it's unwanted. I can't get rid of it, all right? Now, the other half is the compulsion. The compulsion is some sort, and it's different for individuals, is some sort of repetitive or ritualistic behavior that is associated with high anxiety. So what happens is I have this obsession about germs, right? This distressing thought that I'm going to get sick because I've touched something that is contaminated. So now I have a compulsion to get rid of the obsession. And the compulsion might be to wash my hands. So I had a guy when I worked at the prison, and this is a sad story, so brace. This guy's name was Walby. I can't remember his first name, but his last name was Walby. And he was a fairly light-skinned black guy, and he had pink hands. It literally looked like he had pink gloves on. Not like bright pink, but pink nonetheless. But he literally had perfect... it wasn't, what's that disorder, that skin disorder, alopecia? Is that what it's called? The one that Michael Jackson had, where he had the splotchy, white patches, and so that's why he bleached his whole face. He didn't have that, okay? It was just his hands, and I didn't understand it when I first met him. I hadn't had classes in this yet. He had OCD, and he washed his hands so often. He literally washed layers of skin off. He spent hours and hours and hours every day. Every time you looked at him, he's not just washing his hands. He's scrubbing like a surgeon fixing to go perform surgery on the president. Maybe not the president, maybe the Pope, right? Somebody that you actually want to live through the surgery. So he's, it was sad. He had very, very, very strong obsessive compulsive disorder. Now, unfortunately for him, he also had, I think he had some kind of maybe hepatitis or something, which prevented him from working in a lot of different classifications. He couldn't do a lot of other jobs. He couldn't be a porter because he needed more supervision than that. He couldn't work outside because he was in for bank robbery and they wouldn't let him outside. He couldn't do food because he can't be around food because of his health issues. So, I mean, I was kind of stuck with him. So his job, whenever I got there, now imagine, he's OCD about germs specifically. That is his major obsession, is germs and cleanliness. And his job that was assigned to him was to go into the shower and pick up all of the dirty underwear or dirty clothes, but sort the underwear from the shirts, because we wash the underwear separately for some reason. Wash the underwear, separate dirty underwear from dirty shirts and pants. And I got in there and I'm like, are y'all mad at him? Like, why would you give him that job distinction? And they're like, oh, you can't work here, you can't work there. But listen, this is laundry. We also have clean clothes. After they get laundered, they come out, somebody's got to fold them all. Don't you think it makes more sense to put this guy with OCD cleaning or, folding clean clothes versus picking up dirty ones? And it fell on deaf ears. The captain over the laundry said that I was being weak or something. I forgot how he put it, but I was like, dude, I'm sorry if I'm human, but that's ridiculous. So, as fate would have it, he was struck down with some kind of throat cancer quickly after I got over there. So he was out of the picture on medical leave, and I was to report directly to the warden. So my level of management between him and I disappeared, and I then reported directly to the warden. And the first thing I did was reassign Mr. Walby, and I put him on clean clothes detail. And you would think I had saved his life, and I don't use that term lightly because the story's got a really bad ending. But he just kissed my butt. I have never seen somebody more thankful in all of my life. And about 6 months later, I noticed his hands weren't pink anymore. And the other thing that I did for him, by the way, was I got him gloves. I bought with my own money, and I got permission to bring it in, just sterile nitrite gloves. And he's the only one that got them. And I would give him a set, and he would have to bring them to me to dispose of. I didn't throw them away at the prison. I didn't want them to do anything with them. Not that they could have, but you never know what inmates are going to do with things that they can't get from the prison. So I gave only him these gloves, and he worked with those gloves. It prevented him from washing his hands so much. He still washed them a lot, don't get me wrong, but it was maybe a tenth as often. And next thing I know, his hands weren't pink anymore. 6 months later, his hands started to match the rest of his skin tone. So I ended up graduating, and I moved, and he asked permission to shake my hand whenever I left, which is just a defining moment I'll never forget. So he shook my hand, which is a huge big deal for an OCD guy to want to touch another person's hand. So he shook my hand and thanked him for everything that I had done, and I went on to other things, and I chose my successor. It was this guy named Dominic. And about a year later, I called to see what was going on down there. And I called Dominic, and we were, just chatting it up. And I said, so how's Montgomery doing? He tells me what that knucklehead was up to. And I said, how's old Brown doing? Oh, yeah, he paroled out. Oh, no way, Brown paroled. No kid. What about Walby? How's he doing? He goes, you didn't hear? I was like, what? Oh, man. I'm sorry, I can't believe you didn't hear. I'm like, how am I going to hear, right? I don't have any, you're my only connection to the prison. Mr. Walby, after I left, was reassigned out of the laundry altogether. I guess maybe his health issue cleared up. I'm not sure what it was, but he had to go somewhere else. I think he did end up going to the kitchen, and he had to clean up, he had to basically do dishes. So he's scrubbing dirty trays, full of half-eaten food from, dirty, gross inmates. And he did everything to get out of that position, and he couldn't. And then he was denied parole. And then he decided to take a razor blade, and he eviscerated himself. But what's absolutely mind-boggling is the way he did it. He got a razor out of his disposable razor, and he cut his mattress open, and he pulled all of the stuffing out of it, and he put it off to the side of his cell when his cellmate wasn't there. He was off at work or whatever. And he climbed inside the sort of plastic encasing or whatever. He literally created his own body bag and then he cut himself across bilaterally and bled out inside this like homemade body bag or whatever, but without getting any blood anywhere else in the cell. Just super heartbreaking that people weren't willing to work with this guy that had this extreme mental illness, and he ended up taking his life as a result of it. So super sad. Sorry to bum you out. That's a horrible story. I'll try to come up with a fun story to balance that one out a little later. All right, so common obsessions are concerns about contamination or germs. That's kind of the number one. Repeated doubts, inappropriate impulses like shouting obscenities at a funeral. People are just afraid that they're going to accidentally do something like that, or it's just going to come out before they can stop it. And sexual imagery is another obsession. So your people that are porn addicted, sometimes it can be an OCD type thing, right? It's not always, but it can be. Compulsions, well, these compulsions typically battle these obsessions. So if your compulsion is contamination or germs, then you're going to be washing your hands a lot. If it's repeated doubts about something, well, you're going to be checking all the time. So, it's everything from, putting things in a particular order to, sizing things biggest to smallest, or if you had volumes of books, right, that they're in the order. There was a guy that used to be at the gym, now that I think about it, and he would go, all the dumbbells that would be lined up, he would, people would just throw their dumbbells up, wherever, because people suck, right? They should be, numerical, 5 pounds and 10 pounds and 15 pounds and so on, right? And he would run around and he would mix match them and put them all in the right order. And I just, I thought, man, is he being just a really nice guy, or is that an OC? Is it a compulsion? So it just depends. It depends on if he was doing that because in between sets, it's better than just sitting still. You're keeping your blood pumping. You're doing something, right? You're burning some calories while you're resting your muscles between sets, and it's just something productive and nice to do. And it's a win-win situation. Then great. If you're doing it because you can't work out while all of these are in disarray, then that's an obsession. And your compulsion is causing you distress because you're there to work out, but you're not working out. You're cleaning up the gym that you don't even work at. Then it becomes an OCD, a disorder. All right. So it just kind of depends on the level of distress. Hoarding, interestingly, is now a form of OCD. And I have a good hoarding story too, but I'll save that because my other stories have run long. So, my ex-wife's grandparents started losing tons of weight. They were very large people, lived in a farm, on a farm in Indiana, and they just started both losing tons and tons of weight. And their family at first was like, "Hey, good for y'all," and then they were like concerned, right? But nobody's ever allowed to come to their house, and they just said that it was messy and they didn't like people over. Well, finally, kids came to the house, and what they found out was that they were hoarders, and nobody knew it. And they had hoarded so badly, they literally could not get into their own kitchen, so they couldn't eat. So they were just starving, and they had hoarded newspapers, and they had piled them up so high that there was no way to get into the kitchen. All the food had gone bad. They wouldn't go to the store and buy new food because they had nowhere else to put it, and so they just basically didn't eat. So hoarding is very strange to me that would happen. But there was so much anxiety produced at the thought of throwing. It was newspapers. Most of it was old newspapers. For like 50 years, they had never thrown away a newspaper. Their entire upstairs, you literally could not put one newspaper anywhere upstairs. They started in the back of the house in the corner, and they stacked it from floor to ceiling, and then went right next to it, floor to ceiling, right next to it, floor to ceiling, until the whole back wall was floor-to-ceiling newspapers, and then they made a second row in front of that, and then a third row in front of that, until the entire room, you could not put another newspaper room in. And then they went to the next room, and the next room, and the next room, and the next room, and then the hallway, and then the stairs, and they were now confined to just their own living room. It was horrible. So I never saw it, but I heard about it, and it was just god-awful. So hoarding, I never watched that show either, because who wants to watch that for entertainment? All right, OCD etiology, you can read that. PTSD, everybody pretty much knows about PTSD. This also has its own category. This got tons of attention after 9/11. In all of our wars, and all of our military guys went over there and came back. That's actually where PTSD came from. It used to be known as shell shock. People that came back from World War God, it might have been one. It's either World War One or two. I can't remember which, but whichever one. Soldiers were coming back and they were having these symptoms, and people would say, "Oh, he's shell shocked," um, and not really fully understanding it. And so, we have kind of our military people to thank for making us aware of this. Military organizations did a fantastic job of putting this out there for people to talk about and study and get to know. And now I think it's pretty common vernacular. Everybody has heard of PTSD, knows kind of basically what it is. So, caused by the experience of trauma, which can lead to flashbacks, dreams, hypervigilance, and the avoidance of certain stimuli. So, this sign here, I don't know if you've ever seen one of these, but combat veteran lives here. Please be courteous with fireworks. That's one thing that might set somebody off. If you're in a firefight in a war and your life was flashing before your eyes, you have bullets flying all over the place, and then you hear fireworks, right? It reminds you of those sounds. So, be mindful that, it's fun to pop fireworks, but, if I saw a sign like this, I wouldn't do it next to me. I'd find someplace else to go. All right. Mood disorder. So this is the next big major category. So we had our anxiety disorders. We had our little onesie-twosie things with OCDC and PTSD. Now we're on to the next big classification, which is mood disorders. Mood disorders also are called affective disorders. All right. So a person's affect, starting with the letter A, not E, their affect is their mood. That's another way to say that. So mood disorder or affective disorders are characterized by sad, empty, or irritable moods accompanied by somatic and cognitive changes that significantly affect the individual's ability to function. So, kind of a lot packed into that, right? Mood disorders, what they're characterized by, it's got an accompanying feature of somatic and cognitive changes, and it has to significantly affect your ability to function. So this is another one of those ones that especially men don't want to admit to, right? No man wants to admit that they're depressed. It's an acculturation thing. So, we see this more present in women, but it's not because they have it more. It's because they are more apt to report it and talk about it. This irritable mood, the way that it was explained to me is, especially for men, like when you hear somebody's depressed, right? What do you think of? They're sad. They're woe's me. Lips pouting. They're laying in bed or whatever. That's of course what I think most of us picture, right? You don't picture that person that's barking your head off and throwing things and kicking the dog, and you don't think of that angry person as being depressed, right? He's angry. He's not depressed. It's very different. But again, as men, we're sort of told not to have our feelings on our shoulder. You're certainly not allowed to cry or show any kind of human emotion type situation. So we have to convert it to something. Remember that whole Freud thing about energy can't be created, but it can be converted from one form to another, right? That's the whole thermodynamics law from Newton that he borrowed from. So we have this psychic energy that's sadness, right? That's not appropriate, right? Men can't be sad. We're not allowed. That's weak. We're not allowed to be weak, right? We're men, right? We're strong. So we have to do something that's strong. So we have to convert the sadness to anger. It's the easiest thing to convert it to. So sadness is kind of a do-nothing emotion. That's what you want to do when you're sad, is nothing. So we kind of have that switch that we flip, but we can't really control what the floodgates produce. So we flip that switch to convert it from sad to angry, and now we're running around kicking the dog and throwing things across the room and screaming and yelling, because really what we're doing is masking the fact that we're sad. So you see this is real common. This irritable mood is real common in men. So this is broken into two categories: depressive disorders and then bipolar disorders. Now the depression is the same in both. Okay, that doesn't change. The only thing that changes is bipolar has one additional thing, and that is the presence of a manic phase. So we'll talk about that in a few minutes. Now there's all these different kinds of mood disorders, and what changes is how long you have it, where did it come from. That's kind of the different disorders. So looking at just a few of them, the major depressive disorder, or MDD, 5 or more of the following things: depressed mood most of the day, nearly every day, diminished interest in pleasurable activities. That has a name. It's called anhedonia. We'll see that term again in a minute. Significant weight loss. There's actually a formula for it. You have to lose a certain percentage of body weight, or plus or minus so many pounds within 2 weeks or something. So when I say that this is simplified, this 9 things, this was like a lot of information. All of these are very simplified. You have to I literally have to go to the DSM and say, well, how many pounds of weight loss is significant, right? If I lost 2 pounds in a week, that's not significant. If I lost 20, that's obviously significant, but I don't know what that cutoff is. So, and I have to look that up. Insomnia or hypersomnia, sleep too much, sleep too little. Motor agitation, or the opposite. So a lot of these things are spectrums. It can be one end or the other. The bottom line is, remember we talked about that homeostasis, right? That sort of normal midpoint that we tend to stay at. You can move too much, right? If you just can't sit still and you're constantly having to move something, that agitation is not normal. The opposite is psychomotor retardation, or lethargy. You just don't move. You don't get out of bed. You stay laying there for days at a time even. So either extreme is bad. Fatigue or loss of energy, feelings of worthlessness or excessive guilt, diminished ability to think or concentrate, or indecisiveness, and then of course recurrent thoughts about death. Suicidal ideation. Suicidal ideation is people that are daydreaming about suicide. Maybe they think through, like, how would they do it? What method would they choose? Once they think of a method, where would they do it? What time of day would they daydream about it, right? They're I wouldn't go so far as to say planning it out, but it's like they're testing the waters. They're trying to wrap their head around the idea, and it gets more and more specific. First, it's, yeah, I want to do it. And then it's, I don't want to do anything violent. I don't think I would shoot myself. That's too gory. And maybe hang myself, or maybe the carbon monoxide in the garage, or pills. Maybe I'd do those, but I can definitely rule out jumping off a building or something gross like that, right? And then, okay, so now I'm well, what kind of pill would I take? And, I should probably take them, like, late at night so that I could die in my sleep and my spouse wouldn't know until it was too late. That's suicidal ideation, right? Scary stuff. And then suicide attempts. It's very common for somebody that commits suicide to sort of attempt it first. Usually it's a toe in the water kind of thing. Like, can I actually go through with this? And what is the reaction from people around me? If I take 20 pills, that may or may not kill me. If it does, okay, cool. But if it doesn't, then I'm curious to see what the reaction would be, right? And I'll know for the next time that 20 is not enough, that it needs to be like 40. Or maybe that just made me feel really nauseous. Maybe a different pill would be good. So attempts are, of course, obviously very serious. And believe it or not, people have a tendency to downplay those. Oh, he took 10 pills. Oh, obviously, he wasn't actually trying to kill himself. Yeah, maybe he kind of was, right? Or people that do those little superficial cuts, right? And you say, oh, you're not really trying to kill yourself, because those are barely breaking the skin. They're building up the nerve, right? I remember when I was a kid and I finally dove off of the high dive. Do you know how many times I went up and I stood on the diving board and looked down, and it looked like it was a million miles to the water, and then I went back down, and then the next day I'd get up there and I'd stand and I'd go back down, and I did that 50 times before I would bounce on the board. And even then I would bounce 3 or 4 times and then stop bouncing, and then I would get down, and then after that I bounced until I could jump feet first, and then after that I finally started to go, okay, I think I can dive. It's very common whenever you're facing something that's very scary to do these little minor attempts. And you could easily have looked at me that first time that I climbed up, looked down and went, nope, and climbed right back down and said, he wasn't really trying. Well, yeah, I was. I really was trying. I was so scared. I didn't get very far. It took me 50 or 60 attempts before I finally was like, you know what, I'm just going to do it. And I did it. Suicide's the same way. You can't discount those little scratches on the wrist, or those, oh, he took 5 pills, or, or whatever. It's building up nerve is what it is, and it's definitely a sign that something's wrong. Um, all right, couple of stats here for major depressive disorder. This one needs to be present for at least 2 weeks, so obviously a much shorter duration. Not attributable to a medical condition or substance. That's a different mood disorder that is chemical based. Needs to cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. So I'm going to throw my brother under the bus now. So my brother is my antithesis in every possible way. We are just polar opposites. And he hasn't been in a relationship in a really, really long time. So, you know, he's depressed, but he gets up, he goes to work, he comes home, he goes out with his friends quite often. I mean, if you ask him about his life, he'll say everything is great. But from an outsider looking in, I gotta think he's lonely. Never been on he hadn't been on a date in a decade. Not a real one. So it's easy for maybe me to look at him and say, dude, you're depressed. Because he doesn't laugh. He doesn't crack jokes. He's very serious and just kind of robotic, going through life day after day. And just like there's no joy in his life. And so I've often wondered, like, is he lying whenever he says, no, my life is fine. I don't really want to date. It seems like a lot of work and a lot of trouble, and you pour everything into a relationship, and then you end up breaking up, or maybe you get married and everything is great for a while, but then you divorce and look at your life. Oh, that sucks. So I'm not interested. I just can't decide if he's masking or being honest. But the bottom line is, it's not causing him any distress. So there's no diagnosis there. So for major depressive disorder, no mania, no schizophrenia. So you have to do a differential diagnosis to rule those out. It is one of the most diagnosed disorders. Women experience it 1.5 to 3 times more than men. Again, I would argue that's probably not the case. They probably report it 1.5 to 3 times more often. They don't experience it anymore. I think it's even possible that men experience it more than women. I think men have a significant amount of cultural pressure to, have a certain career and make a certain amount of money and drive a certain kind of car and look a certain kind of way. And, of course, women have that last one too. But, I think we have an equal amount, if not more, stress put on us by society than women do. But, again, whenever I'm not living up to those expectations, I'm not allowed to show weakness and be sad. If I'm not living up to my expectation of, being the breadwinner, not making enough money to, sustain a mortgage and everything else, I'm not allowed to just lay in bed and cry about it. All right, that just makes it 10 times worse. Now, if you're a woman and you're, trying to manage your 2 children, right, and you are constantly forgetting a lunch or skipping a soccer practice or late to picking them up, and you just feel like you're not cutting the mustard as a mother, you're not living up to that cultural expectation, and you lie in bed and cry, it's like, well, yeah, of course she is. I mean, she's upset. I mean, of course you should buy her flowers, and you should coddle her, and you should make her feel better. So, there's definitely a double standard where women are allowed to not live up to that expectation, and we tell them that it's okay and you're doing your best and don't worry about it. But if a man is not living up to a cultural expectation, then it's, well, what's wrong with you? You need to get 2 jobs. You need to work harder. And like, why didn't you go to college? And, whatever, but we attack them. So, and, because we know that, then we're just going to hide it and we're not going to let you see that. So, there's a lot of reasons, in the social side of things of why we see these very disparaging numbers between men and women or certain races or whatever. A lot of times it's just reporting magic. It's not real numbers. This is interesting, it says in the book, tends to decrease with age. People between 18 and 29 are 3 times higher than averages for people over 60. I find that very interesting. I feel like the expectation is most people think that the elderly are depressed, and often they are. I mean, think about it. Towards the end of your life, your health is absolutely deteriorated from where it was in your 20s, right? You're constantly surrounded by the fact that people that you've known your whole life are passing left and right. Your friends start dropping like flies, right? Your family are long since gone, so you've lost all of your, your mom, your dad, your aunts and uncles, and all that. They've all passed on. So why would you not be depressed? I mean, it just sounds so normal to be depressed when you get older. I mean, if when you take developmental, you'll see that everything gets better and better and better. We start peaking, and then everything after a certain age is just in decline. Emotionally, we start declining. Physically, we start declining. Psychologically, we start declining. Everything starts going in decline. So yeah, that sounds really sad to me. Um, but the numbers don't, they don't support that. So I don't have an explanation as to why this is, but I find that very interesting that depression tends to decrease. Now I understand why this age it starts. That I understand. You don't have a ton of toolbox. You don't have a ton of tools in your toolbox to combat the pressures of life. Finding a spouse, getting married, financially supporting yourself and a family, starting a family. Like all of these are huge, right? And they bring a lot of stress and anxiety and depression. So I get where that starts, right? But then as you age, you learn more coping mechanisms. A lot of those things that previously stressed you out are done. Your career is over. You're retired. Your family is already created and grown and out of the house. So, those things that were stressful before are now in the past. So, your stressors are less and your toolbox is more full. So I get that, but again, just anecdotally speaking, every elderly person that I've known, I don't have any grandparents left. I haven't for a long time, but in their older ages, they seem super sad all the time. So that's interesting to me. All right, here's some etiology. This one's a little bit interesting. There's a learned perspective. People learn to be depressed, basically that learned helplessness, which we've mentioned. Cognitively, maladaptive thinking about yourself, about the world, about the future. Things like overgeneralizing. Everybody sucks. Every job that I ever have is going to be terrible, right? That's overgeneralizing. Aggrandizing, just making a mountain out of a molehill, basically. Illogical conclusions. This girl dumped me. No girl likes me. No, that girl didn't like you. Lots of other girls will, right? So an illogical conclusion would be like, because this happened with one person, then you think it's going to happen with the next person, but the circumstances are wildly different. So lots of cognitive reasons behind depression. That's part of the reason that therapy can be very, very good, because this can be retrained. All of these things are basically wrong ways to think. And, we don't know that we're doing that. Even that's why psychologists go to psychologists. Most therapists have a therapist, which is maybe odd. But I mean, think about it. Do you think doctors sit around, treating themselves, put their stethoscope in and listen to their own hearts? No, sometimes even though you may be the best doctor in the world, you're still going to go to another doctor, right? Because you're too close to a situation to really see it with proper perspective. So same thing with therapists. Therapists therapize other therapists. And then there's a large body of research that links serotonin to depression and other correlational data. So there's very much a biological component, very much a cognitive component, probably very much a learning component. This one is definitely one of the ones that comes from all sides. And some people might be mostly cognitive. Some people might be mostly biological. So you really have to break this one down for the individual. Other depressive orders, just so you have an idea of other ones that exist. There's one called persistent depressive disorder. It's called dysthymia, and it's depression that lasts for at least 2 years. Major depressive disorder, again, has to be present for 2 weeks, but it usually subsides before that. And then if it persists after that, we change the diagnosis to dysthymia. There is one called premenstrual dysphoric disorder. It is literally just bad PMS, like beyond the normal PMS. There is a substance or medication-induced depressive disorder. So That's what it sounds like. It's depression, but it's caused because you abuse substance or medications. There is a depressive disorder due to another medical condition. So if your depression is caused by the fact that you have two herniated discs in your back, and every morning when you get out of bed you feel like you're 90, and it takes you 2 hours to get going in the morning, you have constant pain and discomfort, and you can't sit still whenever you're doing a lecture, you're constantly moving in your chair, and stretching your neck and your back, then you might be depressed because of a medical condition, that constant pain. Just off the top of my head. And then there's always a catch-all. There's always somebody that doesn't fall neatly into any of these categories, but very much meets criteria. So you don't want to turn loose and say, yeah, there's nothing wrong with you, because something is, but you also don't want to just force them into a diagnosis that doesn't really fit. So there's usually a catch-all, and in this case, it's specified or unspecified depressive disorder, and that gives the clinician sort of the liberty to say, here's the criteria that they meet, and I believe this is unspecified, and then you can provide your own etiology. So, all right, so this is the other one, the bipolar, and so the depression stays the same. So the other half of bipolar that's new is this notion of mania. Mania doesn't sound like it would be bad at first, right? So you have your depression, right, which is your way down here. Your affect is way down here, and then the mania, it's way up here, right? So it's like through the roof, way up there. That's the mania, lasting at least a week, 3 or more of the following symptoms: inflated self-esteem or grandiosity, decreased need for sleep, unusually talkative, or there is a pressure to talk. You have a flight of ideas, like your mind is just racing all the time. Distractibility, increase in goal-directed activity or psychomotor agitation, excessive involvement in impulse choices. So that's why this is bad, right? This isn't just like I'm super happy and laughing all the time like the Joker, right? It's this inflated sense of self-esteem or grandiosity means in a manic episode you can drive 150 miles an hour because I'm the best driver on the road, right? I have never been in an accident. Actually, I've been in 2 accidents. I was going over 100 miles an hour both times. I didn't have my seatbelt on either time, and I walked away without a scratch. So I don't have to worry about this. I can drive as fast as I want to drive. Obviously, very dangerous mentality to have, right? But somebody that's manic might actually think that way. So they could present a danger to themselves and other people. Decreased need for sleep. We've talked about how important that is. Unusually talkative. Somebody that's in a manic episode, blah 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 blah. They don't let you talk to. They don't have a conversation with you. They just talk to you. Let's see. I think I got bit by that stupid mosquito. God dang it. All right. A hypomanic episode lasts for at least 4 days, but not quite a week. Everything else is the same. Depression follows the mania. Same criteria as before, so I already said that. And then this cycle typically repeats. So this ends up being, mania, and then kind of goes back down here to depression, and then it swings back up to, another manic episode, and then another depression episode. Now, how long do these last? Depends on the individual. How long before cycling from one to the other? Is it every other day? Like depressed today, bipolar, or manic tomorrow? Maybe. Maybe it's in the same day. Maybe it's in a week. I mean, it just, everybody's cycle is different. So, you have to kind of get a handle on their time frames, and then you diagnose according to their time frame. So, all right. I'm going to briefly speak on dissociative disorders. Dissociative disorders are characterized by a disruption of and or a discontinuity in the normal integration of consciousness, memory, identity, emotion, perception, body representation, motor control, and behavior. What does all that mean? You start being somebody else. Okay, this is formally known as multiple personality disorder. So you saw that movie, Me, Myself, and Irene. He plays kind of an alter ego of himself, right, with a multiple personality. Herschel Walker, former football player, short, brief stint in MMA. Man, look at those abs. I don't think that man's ever eaten a carb in his life. Jeez. He claims to have dissociative identity disorder. frequently this is found in the aftermath of trauma from the psychoanalysis point of view. The etiology behind this is something happened that was so bad that you couldn't deal with it, and so your ego protected itself by forming a new personality and dumping it off on that person, or creating a personality to help protect your personality. So there'll be like one personality that's dominant over two or three or four or 10 other personalities that kind of is the ringleader for all of them, the father figure for all of them. Um, this is a very divisive topic. Some psychologists believe wholeheartedly that this happens. Others think, from a theoretical standpoint, it kind of makes sense, but I'm just not buying it. And other people think, no, it's absolute crap. People that say that they're multiple personality are just making it up. It's almost a personality disorder. They're doing it to get attention. Where do I stand on it? I don't believe that it exists. I kind of want to believe it because I am very much a psychoanalysis guy, and I like the theory behind where that comes from, and it does make a lot of sense. But I don't think we're capable of it. I personally don't feel that the mind is capable of pulling it off. There's documented stories of people that, can speak Latin in one of their personalities, or they speak with an accent, impeccable accent. I can't do a London accent to save my life. Believe me, if I could talk like I was from London, I would fake that all day long, right? I can't do it, right? I can't pull it off. What if I had a trauma and then I had a personality and then also now I can do it, right? Well, how do you explain that? A skill that I didn't normally have and now all of a sudden I have. I get it. I get that those things exist. And just because we don't have an answer as to where did that come from and how do you explain it, I don't think this is the explanation for it. That's my take on it. So I don't buy it. Dissociative identity disorder is the one I was just talking about. There's another one called dissociative amnesia. That's the inability to recall autobiographical information. These are the people that are like, who am I? What happened? Where am I from? Now, the one thing that I will say is different is traumatic brain injury. If your head goes through the windshield of a car and you suddenly don't remember your name, I'll buy that. Speaking of that, I saw a terrible car accident today. We were passing by and I was all cussing that I was held up in traffic, and then I saw an SUV and it was pretty jacked up, but not the kind that like people are dead from. So I was like, learn to drive. And then as I passed it, there was like this young girl that was laying on her side and mom was holding her. She was probably 13 or 14 and she was having a really bad seizure. And I felt like absolute crap. So here's my apology to the world for being mad at the car wreck and everything. I hope that little girl's okay. But man, that really made me feel sad. But anyway, I felt really like a jerk for being mean about the traffic thing that it caused, whenever obviously other people are having much more severe issues to deal with today than I did for being 5 minutes late to an appointment. So anyways, I had to throw that out there to clear my conscience. Sorry. So dissociative identity disorder is one. Dissociative amnesia is another one. Again, I do think that if there is a biological basis for it, then it's absolutely possible. If it is strictly a psychological thing, that's where I have a hard time believing that our brain is actually capable of that. And I think our brain is capable of some freaking amazing things, but I don't think it's capable of this. A dissociative fugue is a dissociative disorder in which one has a complete loss of memory of their own identity. They travel away from home and they may assume a new identity. I think that's just homeboy's afraid to get divorced, and so he just gets in the car one day and drives somewhere else and claims, oh, I don't remember who I am. I forgot that I was married, and I forgot that I lived there, and now I'm remarried, and my name is John Smith. And I just think that people that get busted doing that are exactly that. I think they were busted, and I think they say that they have amnesia, and I don't believe them. Depersonalization or derealization disorder is interesting. Experience of detachment or being an outside observer with respect to their own thoughts, feelings, sensation, body, or action. I did a little research on this. It's very, very rare, by the way. But it's people that they feel like they're kind of in the matrix and like nothing is real. Like they're in reality. They're not distanced from reality. They understand this is reality, but it doesn't feel real to them. And there's some evidence again of a biological basis for this. Some hardwiring in the brain that's slightly miswired or misfiring, I guess I should say. There's another one. Individuals or objects are experienced as unreal, foggy, dreamlike, lifeless, or actually, that's the same one. There's another disorder where people can see faces and recognize whether they've seen it before or not, but not know who it is. There's, and I don't know if it's the same or similar, but that has to do with there's a part of your brain that recognizes faces, and it is, what's it called? I think it's Wernicke's area in the brain, or is it Broca's area? Broca's for something else. I think it's Wernicke. It's getting late. Sorry. There's a particular part of your brain that breaks down faces and remembers whose face belongs to what name or whatever. And these people, that part of the brain is messed up. So when they see somebody's face, they don't really remember who it is, and like they see their husband every day, and it feels like it's not them, because they don't really recognize them. They see the face, they know the person, they don't know who that person is, and they don't believe that that's really their husband, even though they've lived in the same house with them for 40 years. So that would be sort of a dissociative disorder. I think it's medically based, biologically based. Again, it's super, super rare. So, I mean, there's a couple dozen cases ever in recorded history. So it's not 2% of the population or anything, but crazy stuff. All right, so next, classification, I guess, of disorders: somatic, symptom, and related disorders. So this used to be called somatoform disorders, and they did away with that, and now they call it somatic symptom. All right, this was majorly overhauled in this last DSM that just came out 5 or 6 years, 7 years ago. The reason I think that it was mostly overhauled, and they put fewer criteria in, and they changed some of the terminology and everything, is because this is where, as clinicians, which I'm not, but when clinicians, sometimes I speak as if I am, so I want to clarify that, but sometimes that's why I say, because I say we, and I'm not actually doing it, but we as psychologists will get referred to us from doctors. This person came in and they have all these medical issues, but we've run every test. There's nothing wrong with them. They're 100% on all these tests, but then they're still saying that they, can't see red or whatever, or they, but we've given them colorblind tests and they pass. So it doesn't make any sense. So we think there's something wrong up here. We're going to refer them to a psychologist. So that happens a lot. So because there's that bridge, right, between psychology and the medical community, these somatic disorders are talked about this is sort of their expertise, right? So it makes sense that this part of the DSM would be written more for doctors and a little bit less for psychologists, because they deal with medical issues, right? But they're psychologically based, if that makes any sense. So anyway, I don't go into a whole lot of detail in these. Most of the time, you refer these out after a couple of visits, so I don't know anybody that specializes in this particularly. I think a psychiatrist who has obviously the medical degree, unlike a psychologist, but then also has the training in psychology, would be probably the best person to look at somatic disorders, more so than a psychologist, because a psychiatrist walks both of those worlds, right? Psychology and medical together. That's why they're a psychiatrist. So this I kind of leave to them. I'm not going to really go through these too much. Conversion disorders, one or more symptoms of an altered sensory function. So conversion disorder is, I saw a murder and now I can't see the color red anymore. That would be a conversion disorder. I watched somebody get an IED, blew off their legs, and now all of a sudden I can't walk. And so they're in a wheelchair. Medically, there's nothing wrong with your legs or any reason why your legs would stop working, but suddenly you can't walk. That would be a conversion disorder. Factitious disorder is exactly what it sounds like, made up. Let's see. Okay, let's get to this one. All right, schizophrenia. Everybody's heard of schizophrenia. What is it? Okay, there's a lot of things to this. So let's go through this one real quick so we can wrap this one up. Schizophrenia the official title is Schizophrenia Spectrum and Other Psychotic Disorders, because there's about 5 or 6 of these. Um, Abnormalities in one of the following 5 domains. 1, 2, 3, 4, 5. I think I have 6 things listed here. So, all right, the big one, the main one, delusions. What is a delusion? A delusion is a false belief. Um, Now, delusion by itself is not particularly scary. I had a call one time. This woman, very nicely dressed, young black woman, very pretty, very nice apartment. And we got a call from the management because she was constantly, every day, several times a day, was complaining to management very nicely, very professionally, not angrily or yelling or anything like that, but complaining that at night, every night, people were sneaking in her apartment in the middle of the night and poisoning her food. And she wanted the locks changed. So they changed the locks. And then the next night, she would say, yep, they did it again last night. And they said, do you have a chain on the door? She said, yep. Was the chain still on when you woke up? Yep. Well, then how did they get in and out? I don't know, but they are. So, I mean, very quickly, you're able to see that, no, they're not, right? Nobody is coming into your apartment. They said set up cameras. So she actually did that, set up a camera, and nothing was on the camera. And then you asked her to explain it, and she says, well, I don't know how to explain it. I guess they manipulated the feed somehow. Well, I mean, why? Well, what would be the motive? I mean, what enemy do you have, right? Well, I don't have any enemies. Okay, well, why would they be what makes you think, well, I don't feel well? Have you been to the doctor? Yeah, and they can't figure out what's wrong with me. So, very clearly a delusion, right? A false belief. Now, she did not have the rest of the stuff. She did not have schizophrenia. I don't know what her diagnosis would have been. I didn't spend enough time with her, so I don't know that. But, that was the very first, I think, clear delusion that I ever, witnessed with my own 2 eyes somebody express. And it was just remarkable to me, the amount of confidence that she had in her belief. 100% knew that she was right, and she obviously wasn't. So what do delusions look like? Well, in schizophrenics, they kind of take on a theme a lot of time. They can be persecutory, so you feel like the world's after you, somebody's after you, right? They're almost like paranoid. Somebody's out to get you, right? You, for whatever reason, have been marked, and they're going to stomp you down. They're going to get you fired. They're going to make your friends hate you. They're going to get you kicked out of your building. They're going to, whatever, right? That's the first one. Referential, I don't remember what that one is, to be honest. I don't remember what that one is. I'd have to go back and look at that one. I forget that. I'm going to admit that I forgot something for once. Religious delusions, very, very common. Grandiose, that's very common. People think that they're the head of a intelligence agency, or they're so important that the president is going to send assassins after them. That's kind of a combination, right, of grandiose and persecutory. So erotomatic, that's sexual in nature. They believe that everybody's in love with them, or every girl that walks by secretly wants to have sex with them. That one's not nearly as common, but it does explain sometimes people who are charged with. I have read a couple of cases before, people that were charged with aggravated sexual assault or sexual assault, where they sexually assaulted somebody, and then their defense was, well, they wanted it. And the person was like, I don't even know you. I've never seen you before. You jumped out of a bush and grabbed me. And they were like, well, yeah, I know you've never met me, but I mean, I can tell by the way you looked at me, you wanted me. That would be, if they believed that, they really believed that, then that would be an example of this. And then nihilistic is, the end is coming. The end is near. The world's about to end. That kind of thing, which, they might be right now. All right, so that's delusions. That is different than a hallucination. A hallucination is a false perception. So you see something that's not real. You hear something that's not really there. Those are the 2 most common, but it can be tactile. You can feel bugs crawling on you. That would be a tactile hallucination. So you can really have a hallucination of any of your senses. But usually seeing them and hearing them are the top 2. So let's see, do I want to get to that? Yeah. So let me tell you this quick thing, and I should have put this on the video link, but I did not. So you might have to Google this, but it was interesting, and it was funny how this worked out in my life. I was flipping the channels one night, and I think it was like late high school, and there was something on 2020. I don't watch 2020 or Dateline or 60 Minutes or any of those shows. I don't care about that stuff, right? But I was flipping through, and for whatever reason, something caught my attention, and I stayed and I watched it. And it was this company, a pharmaceutical company called Janssen Pharmaceuticals, and they produced a pill for schizophrenia that was supposed to try to help out with hallucinations specifically. And virtual reality was like a brand new technology, and it was like just coming out. So they got together with a VR company, and they created this VR headset with earpiece and everything. And it was 2 videos that was made so that the average person could experience what it would be like to be schizophrenic and have hallucinations. And so they put it on just regular people, and they put it in the camera so you could see it. And the story, because you don't really control the story, you're kind of a bystander, but you can look around and pan it left and right a little bit, but you're still sort of going along with the story. So the story was, you have to get on a bus, go a couple of blocks up, get off, go into a pharmacy, and ask to have your prescription refilled. That's the whole thing. Well, while you're doing that, right, you get on the bus, and you're instantly sort of inundated with audio and visual hallucinations. So you see the back of everybody's head on the bus, but then all of a sudden, like, one of their heads spins around and it looks like a demon. And then over here you see like a rat that's crawling up the ceiling, but then it just disappears. And then you hear these people, and they're like, "Do you see that person over there? What is wrong with him?" And they're saying these like mean things. It's always mad. It's always bad and angry. It's never a hallucination. Oh, that guy's really good looking, right? There's no such thing as a positive. Like, I've never heard of that, right? It's always these negative, mean voices that are saying these horrible, either death and dying kind of things, or just beating you into the ground verbally kind of thing. So you go the whole way to this pharmacy like that, and you experience that. And it was like, oh my God, this is like awful. But the powerful thing in that video clip was, they had this guy that had been, and he was very well educated. I think he was like an architect or something. But he had an advanced degree. He was very intelligent. But while he was going through college, and this usually whenever this onsets is roughly early to mid 20s, he started developing schizophrenia, and it was really bad. He had all these hallucinations and delusions and all these different things. And he suffered. He was homeless, lived under a bridge, had lots of interactions with the police, was thrown in jail, was thrown in psych wards and all that kind of stuff, until he finally got it under control with medication. And once it was medicated, he could actually carry a fairly normal life. And so he did, and he done very well, for himself once with the proper medication. Only having to live with the side effects of said medication. So, that was an issue, but was able to live. Well, they put this VR headset on him, and they wanted to ask somebody who has experienced real schizophrenia, how real is this? Like, how accurate is this? Over the top? Is this like kind of a Hollywood version, or is this like pretty on the money? Because they developed it through talking to people that have schizophrenia, so they try to make it as realistic as possible. So they put this on his head, and he starts watching it, and he has a panic attack, and he has to take it off, and he says, I can't. Oh my God. And then once he calms down, he comes back and he goes, that is exactly what it is like. The voices are exactly like that. The visuals are exactly like that. I mean, except this is very computer model looking. It wasn't particular, it was probably the late 90s. The visual effects weren't nearly what they are today. So it looked very computery, not realistic. He said, that's the only thing. He said, in real life, it's way worse because it looks freaking real. So I just remember, I think that's where I was like, oh my God, I can't believe people live with this. Holy crap. And even as well before I did all my, prison guard and cop stuff that made me cynical towards the world, that I was like, oh, these poor people, right? So then, oddly enough, whenever I was putting together the CIT class for the police department, in my research, I came across that same video. And I thought, wow, I'm going to show that to the video. Well, it was such a powerful video that the other guy, Herb Cotner, that was making this class, I guess, with me, reached out to the company, and they actually sent somebody to our classes that had the actual VR thing with the actual program. So how random is that? That like almost 20 years later, after just randomly seeing this on TV and thinking, oh, that's interesting, I'm now wearing that headset and I'm using it as a teaching aid to teach cops about the reality of what these people live with. And you know, and the reason that we did it was because as a police officer, you pull up to a scene, you give somebody an order, and you kind of expect them to follow it. Hey, you, come here. Hey, drop that hammer and walk over here. But drop the hammer first, right? And that makes sense. You would expect an average person to follow those commands. But when you have in this ear, yeah, that person sucks, you should kill them. Yeah, that person. And then in this ear, you hear, you're worthless, you're nothing, you're no good. And that's just two voices. Really, there's about 10. And you hear all this stuff, all these mean voices, and then there's a cop voice going, hey, you, come here. Man, you don't even notice that. So, you know, cops get to these situations where there's this mentally ill person and they're not following orders, and so they get pissed off, and then they go aggressive on them. And it's not something to get pissed off at. They probably didn't freaking hear you. And you know how you really need to get their attention? You talk to them like this. Because if you're like, hey, you, come over here and talk to me, you sound just like all the other voices because they're all yelling and they're all angry. And so are you. So you blend right in with 10 other people. So the best advice that we give them is be friendly, be caring, be, you know, almost loving with your voice. And even if you don't feel those feelings, right, if you're faking all of that, that's okay. What you're doing is you're standing out from the other 10 negative, bad voices that they're hearing. And I promise you're going to get their attention. And everybody that went through that class, I mean, I would get emailed almost daily for months and months and months going, oh my God, I used that and it freaking worked. As soon as I started talking to him, they looked at me. And I've dealt with this guy before, and he wouldn't even look at me the first 10 times I called out to him. And now I tried talking to him in that different tone like you talked about, looked right at me. It works. So I just think that's cool how life brings you, you know, full circle. And I'd seen this and then, you know, run into that same program again. All right, back to reality here. So delusions and hallucinations, very, very common abnormalities in schizophrenia. The next thing that's also very common is a disorganized thinking, which you see prevalent in their speech. It's very hard to follow their stories. They go off on tangents a lot. They don't finish thoughts. Then they will have other thoughts that they pick up halfway through. They didn't articulate the first part of the thought, and they just kind of randomly start, and you're trying to figure out a connection between these two thoughts, but there really isn't one. That happens a lot. Derailment or loose associations, tangential, it's called aphasia is the word for it. We just call it word salad. It's just a bunch of words randomly kind of thrown together that really don't tie together anything. Grossly disorganized or abnormal motor behavior, everything from catatonia, where they don't move at all, to they can be just making really weird, bizarre movements. I don't see a whole lot of that. That one's not as high on the list. So all of those are what we call positive symptoms. Now, just like we talked about classical conditioning, positive doesn't mean good. Okay, it means in addition to. So what that means, these positive symptoms are things that are added to human behavior that aren't normally there. Okay, if you see stuff that nobody else is seeing, you're adding some perception that doesn't exist. If you believe something that everybody else knows is not real, right? You're in addition to reality, you're adding something. The disorganized thinking, right? If you're adding all of these words to a conversation and they don't have any place there, right? So these are all positive symptoms. And I distinguish that from the negative symptoms. These are things that we should have as part of the normal human experience that we don't, okay? Things like diminished emotional expression. So very little or absolutely no facial expressions, very robotic in how they talk, no eye contact, The intonation of speech is very flat. Very, they don't talk. They talk like this. Everything they say like this. They don't go. It's typical when you ask a question. You say, "Would you like something to eat?" Eat. Yeah, that word goes up, right? In the English language, when you ask questions, normally questions the inflection goes up, and statements the inflection goes down. Inflection goes down. Da 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 da. That's what I mean. Or, do you hear what I'm talking about? It goes up, right? That's intonation. They don't have that. Everything sounds the same. They have absolutely one note, and every word hits that same note. It's just like a robot. Couple of words here. Avolition. Avolition is a decrease in motivated, self-initiated, purposeful activities. So somebody that has avolition will not bathe, not eat, not get out of bed, not watch TV, things like that. Alogia is that diminished speech output. They're just very quiet, right? And anhedonia is, we mentioned before, a decreased ability to experience pleasure. So I had a client that was schizophrenic, and the lady that I worked for when I was working as a therapist was the head of counseling services, I want to say at UT Arlington. I think that's the college she was at. And then she went off and started her own private practice. And so she had students that she had seen whenever she was over at the college that when she went to her private practice, followed her into private practice and wanted to continue therapy. Well, this was one of her students, and he was schizophrenic, and he was odd. This isn't particularly common. He didn't have any positive symptoms, but he had all the negative symptoms. So he didn't really have delusions. He didn't really have hallucinations. He didn't have those things, but he was like a robot. He would not look at you. He never spoke. He never smiled. So therapy, as you can imagine, is pretty hard, right? Whenever they're not talking to you or looking at you. So they come in and you're trying to have both sides of the conversation. And I mean, what's the point, right? But then he would go home and he would write 8-9 page long email. And he would express to, I really liked it when you were talking about this and when you were talking about that. And that really made me feel happy and really made me feel good. And I'm going to try to work on that. And, one thing that I didn't share with you was, and he would just blah, 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 blah. And it would be tangential. He would jump around. Sometimes one sentence would be half a page long, no punctuation. And it's really like 7 sentences all kind of spliced together. But you have to read it 6 times to really sort of make sense with it. And so there'll be pieces that don't make any sense. So you're kind of left putting this puzzle together. So that in order to try to get him to communicate, one of the things that his father had told us is that he played a lot of Xbox. And so she had been seeing this guy for years, never got him to speak a word, right? So she asked if I could sit in the room, and he didn't answer, so she just assumed it'd be okay. So I was in the room, and he walked in, and he turned around and walked right back out, got in the car, and would not come back in the building. So that was a no-go. So the next time he came in, I was in the next room, and I was watching through a video feed, and she told him that existed, and he turned away from the camera, but he didn't leave the room. And then the next time, he didn't turn away from the camera. And then the next time, I was able to stand in the doorway, and he didn't run away. And then the next time, I was finally able to stay in the room, in the back corner with a desk in front of me. So it was like a barrier. And he was all the way in the other corner, and he didn't leave the room this time. And that's how long it took us to just get me in the room with this guy. And then, I would do some talking, and he said that I sounded like a nice guy, and I knew what I was talking about, and blah, blah, blah. And he was impressed with some certain inferences that I made about, his thoughts and feelings. And so one day I brought my Xbox up, and I brought the same game that he always plays, and I'm not a huge Xbox guy, but and I had the game, and I'm not particularly good at it, and I was like, hey, do you want to play? And he wouldn't say yes, so I said, okay, well, listen, I'm going to play, you do what you want to do. And I started playing and dying a lot, and next thing you know, he came and sat next to me, and he played, never smiled. He absolutely destroyed me, right? And I don't remember what we played. I think we were playing a Call of Duty game or whatever, but I mean, I was getting like 1 or 2 kills, and he was getting like 30. So we get done playing, and he puts down the controller and he walks out and doesn't say a word, and he writes like a 20-page long email about how that's the most fun he's ever had. He's never played Xbox with another person before. He felt like a normal person, a normal boy with a normal friend, and it's a memory he'll never forget. But you would never know by looking at him, because he sat there just like a robot, just. And I would very compliment him, like, "Oh man, you're really good at this. Can you show me how to do that?" And he wouldn't answer me. He would just do. And I would say, "Okay, well, how do I change weapons?" And then he would change weapons, and he would kind of show me, but wouldn't look at me. And it was just very, very interesting. Lots of negative symptoms, no positive symptoms. Still a horrible thing to live through. Now, one of the things that I will say, I'll just get this to the bottom of this, medications can help alleviate the positive symptoms. Nothing can be done about the negative symptoms. So that inability to experience pleasure, that refusal to kind of speak in any kind of way, if you got those, you got those. They're not going away. You're not going to, no therapy is going to make that go away. No medicine is going to make that go away. That's the cards you've been dealt. The positive symptoms, the delusions, the hallucinations, the jumbling of words or whatever, there are medications, antipsychotics out there that will dramatically improve that. Those same medications have a lot of side effects. Weight gain, kind of this mental fogginess, right? So you're not having the hallucinations and delusions, but you kind of just feel like you're in this mental fog, like you're not quite connected to reality. So they're still pretty bad. They're not going to live this great life after that. Other psychotic disorders, there is something called delusional disorder, presence of one or more delusions for a duration of a month or longer. That might be like that woman from the apartment complex. Brief psychotic disorder, presence of either delusion, hallucination, disorganized speech, or behavior that lasts for at least 1 day but less than a month. Schizophreniform disorder is 2 of the 5 categories during a 1 to 6 month period. Schizoaffective disorder is basically schizophrenia with a major mood episode. So this is interesting to me that most of the time you would say the person has generalized anxiety disorder comorbid with major depressive disorder. So they have this disorder and depression. And you would say it that way. Or you would say they have major depressive disorder comorbid with whatever the other one is, right? There's that comorbid word meaning occurring at the same time with this other disorder. But for some reason, with schizoaffective disorder, they gave it its own name, its own thing. You don't say they have schizophrenia comorbid with major depression, which is what that is. It's schizoaffective disorder. They didn't do that with anxiety and depression, which are very often comorbid with each other. It's not, they have, what would it be? Anxiety affective disorder. That would make sense. They didn't do that. I don't understand why. I've asked that to people that are licensed and nobody can give me an answer. All right, here's the fun one. Let's end with the fun stuff. Sexual dysfunctions. Persistent, recurrent, and distressing problems involving sexual desire, arousal, or the pleasure associated with sex or orgasm. So there's a lot there. Sexual dysfunction doesn't just mean a guy can't get it up. That is a dysfunction, but some people don't even want sex. That would be a sexual dysfunction. We are sort of hardwired. That should be a need for us. And if you're asexual, you just don't have a sex drive at all, that is considered a sex dysfunction. Maybe you can get it up, you can do it, but as soon as they're done, you're like, oh good, I can stop. You just don't get anything out of it. Maybe you can do it and you can last for days, but you can't ever climax. That is a sexual dysfunction as well. Could be biological, could be psychological. Everybody's different. Here's the fun stuff. Paraphilic disorders. These are sexual disorders in which recurrent sexual urges, fantasies, or behaviors involve non-human objects, children, or other non-consenting persons, and we're going to break all of these down. There is a difference between paraphilias and paraphilic disorder. Let's talk about paraphilias. All right, here's the scary thing. In descending order, these are the most common. Of all the sexual dysfunctions, The most common is pedophilia, sexual activity with children. That sucks. I wish this was the very last one, right? Because obviously there's a victim involved here, right? Some of these there's really no victim. It really is the definition of a victimless crime, right? But this one, the absolute worst on the list, is also the most prevalent. That's very disheartening. All right, the next one is exhibitionism. This is somebody who gets sexual satisfaction or arousal from exposing them. It's really not just genitals; it's themselves, right? Somebody that gets off to showing off to strangers. Um, Again, when you're looking at it as a disorder, okay, exhibitionism has to cause distress. If you're running around flashing people, the classical trench coat, nothing on underneath it, flashing strangers, and they're calling the cops, and you're running away and all that, absolutely, that's a disorder. But then, people, girls on spring break that go to wet t-shirt contests, right? And they're exposing themselves to strangers, and they like the attention. Would that be a disorder? Would it be exhibitionism? Well, again, the genitals part, I don't think that I agree with that in this definition. I think if you expose your breasts, that would be an exhibitionist. It doesn't always have to be genitals. I think we can include breasts. So let's say that you're one of those, girls gone wild girls, right? Is that exhibitionism? Yes. They are exposing themselves to strangers. Absolutely, no question. What about strippers? Are strippers doing exhibitionism? Absolutely. Is it a dysfunction? Well, it's not causing distress, right? It's causing them to earn $1,000 a night. That's not exactly the definition of distress, right? It got that girl that cool Girls Gone Wild T-shirt that she really wanted, right? So her dad will be proud or whatever. I don't know. So, yeah, it's not always a disorder. Sometimes it's just an eccentricity. I can't say that word. All right, so the opposite of exhibitionism is voyeurism, and that's being on the other end of it. You want to watch non-consenting people, unaware people. So the voyeurism thing could be very bad, right? Maybe you like going to sex clubs and not necessarily partaking, but sitting back and watching everybody around you do whatever they do in those clubs, and then you go home and enjoy the fantasy. Would that be a particularly bad kind of voyeurism? Well, again, there's not really any victim there, but people that are afflicted with an absolute disorder, right, and their need for voyeuristic activity is so strong that they are putting cameras in bathrooms or taking pictures under changing room partitions, things like that, then obviously voyeurism can reach criminal levels. So that can be very bad. Here's an interesting one. It doesn't occur as much here as it does in other parts of the world, specifically Japan. Japan is really bad with this one. It's called frotteurism. And frotteurism is simply touching or rubbing up against non-consenting persons. This apparently happens tons in Japan in elevators that are super crowded and on their super crowded subways. Like Tokyo is one of the most populated cities in the world, right? So they have subway system like New York does, and they are packed in like New Yorkers are. But in America, if you bump into somebody, they're going to let you know real quick, right? But we have a very different culture than they do there, right? There, everything is much more sort of not as tightly wound, right? So you bump into a girl there, they're more likely to be like, "Oh, sorry," even though you bumped into them, right? If I bumped into a girl in a New York subway, I'm sure she'd tell me about it, right? So it's a little different. Probably can't get away with it over here. So I guess because of their culture, it is allowed for men to be able to get away with that a little bit more in that part of the world. So that's frotteurism. That's an interesting one. Fetishism is the use of any inanimate object. You can have all kinds of fetishes. Right? People have latex fetishes, or I don't know, masks, or feet. Foot fetish is a big thing. Sexual masochism is being humiliated or forced to suffer. The opposite role is sexual sadism, that is inflicting humiliation or suffering. So if you're the boss and you're telling this person to lick your shoes, you are the sadist, they are the masochists. Okay? If I am putting a leash on you and walking you around on your hands and knees, I am the sadist. I am inflicting that humiliation on you. You are the masochist. You are enjoying that humiliation. By the way, if you didn't know, whenever you hear the sexual terminology S&M, that's what it's referring to. Sadism and masochism, S&M, if you didn't know that. All right, the next one is transvestic fetishism. So this is a specific kind of fetishism that is cross-dressing. And believe it or not every man that dresses like a woman is gay. I didn't know that. I thought if you're a dude and you wear a dress and a wig and makeup, you're probably trying to attract a dude, right? That's not so. They just like dressing like a woman for whatever reason, why, whatever gets, whatever floats your boat, as I say. But yeah, they will dress like that and then dress back down as a guy, and they just do the transvestite thing on the weekends, and then they're married with kids on the rest of the days or whatever. Super strange. And then there's the catch-all. The paraphilia is not otherwise specified. You can Wikipedia that and see a list of the more rare ones. There's things like necrophilia, people that have sex with the dead. Morticians do this. Not all of them. I'm not trying to lump them in there. But, when you work around dead bodies all the time, it's not as gross. It's like, it's a dead body, whatever. So, yeah, there have been several morticians and morticians' assistants that have been busted for that. There's something called coprophilia, which is people that gets off to fecal play. They literally poop on each other or on themselves. And there's something about just knowing that you're being deviant. It's something about knowing that it's wrong that makes it exciting. That's can be true for anything, right? Anything you do that you're not supposed to do, right? You get that rush of adrenaline or whatever. So, these things sometimes start off small and then they end up growing bigger and bigger because of tolerance. You do something and you get off to it and then eventually it doesn't work anymore. So you have to take it to the next step and then the next step. So, first it's just porn and then porn gets boring, right? So then it's more specific porn. Maybe it's like S&M porn and then that gets kind of And then it gets to be maybe violent porn and then it's like, oh, this is great. And then it's like, this is boring now too. So where do you go from there? Well, then the whole fantasy thing starts to become, maybe it's a reality thing. Maybe now I want to get out there and start peeping in windows. And now you've done the voyeurist thing. And then that's kind of gets boring. And then you got to take it a step further. So, if you look at like your Ted Bundys and your people like that derive sexual pleasure from necrophilia and stuff like that, it doesn't start there. It usually builds up to there. It started in Bundy's case. I know that it started with regular pornography, and then it went from that to very violent pornography, and then he started having the fantasies of doing what he was seeing done in the pornography. Even though this might be, adult film actors or whatever that are portraying this S&M, they're probably not enjoying it. They're doing it for the paycheck, right? But they're pretending to enjoy it, and so he wants to go out and find somebody that actually enjoys that and doesn't, so he just does what he did, right? So, there's a big argument that these things are made over time because we allow these things in our society. All right, that brings us to the last thing, second to last thing, personality disorders. These are some of the most fun to talk about, but I've been talking for hours now, it feels like, and I've got to wrap this up. It's like after 2 o'clock in the morning, so I'm about ready to be done. All right, so there are 10 specific personality disorders now listed in the DSM. Some of them are very obviously different. Some of them, they're very, very similar to each other. So doing a differential diagnosis between two of them is a little difficult. People that have personality disorders let me read the definition. It's an enduring pattern of inner experience and behavior that deviates markedly from the expectations of the individual's culture, is pervasive and inflexible, has an onset in adolescence or early adulthood, and leads to distress or impairment. Now that last part's a little tricky on this. So I've been harping on the whole distress thing. If it doesn't cause you distress, it's not a disorder, right? As a clinician, you have to look and say, well, you might not think it's causing distress. Just like my brother might say he's not depressed because he doesn't have a relationship. But, I mean, you can see pretty obvious signs of depression. I mean, he eats constantly. That's his comfort. Um, his sleep is terrible. He's got a lot of insecurities. A lot of fear of rejection, things like that. A lot of issues going on, right? It's just all masked depression. So as a clinician, I even though he says there's no distress here, I'd probably still label that. I don't believe that. I think that's malingering, and I would probably give him that diagnosis. With personality disorders, it's a lot like that because they will hardly ever tell you that there's something wrong with them. They will never admit to a distress. They will say their life is great, they're perfect, they're awesome, and you're the one with the problem, right? So you almost have to assign the distress based on what you see in their life. Broken relationships, inability to hold a job, banishment from their family. They've been ostracized, they're not well liked. Things like that. You have to see that distress for them because they're not going to admit to it. So a few of them that I don't go into a lot of detail because these are a little more complicated to study. There's a little more theory behind them. The symptoms are a little weird. Histrionic personality disorder. This is more common in women than men. Pattern of emotionality and attention seeking. Again, the criteria they're kind of gray areas. Paranoid personality disorder. Pattern of distrust and suspiciousness. They think everybody is out to get them. They think everybody's lying, everybody's cheating, stealing, all that. I mean, they're paranoid. Constantly a paranoid person of everybody, distrustful of everybody. That one's kind of interesting. A schizoid personality disorder. This is a pattern of detachment from social relationships and restricted range of emotional expression. So it looks a little bit like some of the symptoms that you see in schizophrenia, some of the negative symptoms, right? You see a little bit of that here, but then you see like a personality deficit that there's capability there. Like your schizophrenia negative symptoms people, they don't have the ability to form friendships, right? You can't talk to them, you can't look at them, you can't make a friend like that, right? People with schizoid PD have the ability, but they just don't do it. They don't choose to engage. They're like introverted, but even more than a normal introvert. And then on top of that, restricted range of emotional expression. So schizoid personality disorder, not particularly common one. It's a differential diagnosis between schizophrenia and depression. Dependent personality disorder, fairly new one. Pattern of submissive and clinging behavior and need to be cared for. This kind of was born from battered women syndrome, where people are like, why do you keep going back to that guy? He keeps beating you up. There's got to be a reason for that other than, well, he pays the bills and you don't want to be homeless, because you wouldn't be homeless. Somebody would take you in, you'd date somebody else, or they wouldn't beat you up, or you'd go to your family member's house or whatever. But some people just stay for it, and they needed a name for that. Battered women syndrome doesn't sound great, right? So they went with dependent personality disorder. And then there's obsessive compulsive personality disorder. This is different than obsessive compulsive disorder. This is somebody whose pattern of preoccupation with orderliness, perfectionism, and control. There is kind of an obsession, kind of compulsions, but they're not overbearing. It's just somebody, like when we say like, oh, look at this person's pantry, like all the cans are facing labels perfectly out instead of just being thrown in there. That's super OCD. Yes, but doesn't it make sense? When you open your pantry, you can see everything. You don't have to twist and move stuff to see what's behind it and all that kind of stuff. So if there's a sense to it, right, then I might not call it OCD, right? They didn't do it because if they didn't do it, it caused anxiety. They did it, and it makes a lot of sense. They probably spent a lot of time doing this. but their obsession with orderliness and effectiveness is probably beyond the realm of normal for most people, right? So, yeah, that might be something to look at for diagnosis. Borderline personality disorder, this is more typical in women. This one's a really weird one for me, and it's a really hard one to diagnose. Instability in interpersonal relationships, self-image, and emotion. It seems like it's all over the place. I've never really gotten a handle on borderline PD. It's to me, it's the most difficult one on the whole list to recognize and understand the criteria, because I feel like, I mean, hell, we've all had an interpersonal relationship that was unstable, right? We've all broken up with somebody. Well, you won't break up with somebody if you have a stable relationship, so we've all experienced that. Um, Everybody has some kind of issue with their self-image. Very few people are like, I'm awesome. Everybody thinks that, they could lose 5 pounds here, they could do this, or they could do that. Everybody has some issue with it. So, seeing this as a diagnosis is just very difficult, I think, for most people. But most people agree it's the hardest one. But certainly for me, I admit I can't do it. Here's the big one. All right. Antisocial personality disorder. When we talk about somebody who is a psychopath, this is what you're really talking about. When you talk about somebody that's a sociopath, this is what you're talking about. It is a pattern of disregard for and violation of the rights of others. 3 or more of the following. Most of the time you see more than 3. Some of them you see almost every time. There are certain ones that are more prominent. Failure to conform to social norms with respect to lawful behaviors. They don't care about the law. They don't care about social norms. They just do what they want to do, right? They do what they want. Nothing applies to them. They know they're breaking the law. They know what the law is. They just don't care, right? This one you almost always see. This is probably the number one, but it's listed as the second one. Deceitfulness. Repeated lying, use of aliases, conning others for personal gain or pleasure. People are not people. People are just objects. And sometimes objects are in your way, and what do you do when an object's in your way? Go through it, you go around it, you go over it, you go under it, right? And by any means necessary. So if you're in my way and I got to go through you, maybe I have to kill you. And you watch some of these shows on Netflix about these psychopaths in prison and stuff, and that's the way they say. They say, "Why'd you kill that guy?" And they go, "Well, it wasn't anything personal. I didn't dislike him, but I needed that money in the register, and he was the one opening the register, and so he was in my way, so I had to kill him." They're like, "Yeah, he was opening the register, giving you the money. He wasn't in your way." Well, I didn't look at it like that. I mean, he saw my face. He might be able to identify me later, so he just had to be taken out. It's just that simple. Never shedding a tear, or no sense of remorse or feeling that that was a human life that they took. It was just an object in the way, and that object needed to be eliminated. And scary enough, that's kind of how the military trains soldiers, and that's kind of how cops are trained too. This is a threat in the threat. I had an interview one time at a police department, and they said they always put you in these impossible scenarios, and they want to judge how you answer it. And it's not the right or wrong answer. It's the fact that whatever answer you give, they're going to try to make you feel like that's wrong, and then see how you act when you're flustered. So they asked, you're walking on a beat with your partner, and all of a sudden out of nowhere, this guy jumps out, hits your partner and you fly back, he flies back. Bad guy goes over to your partner, takes his gun out, and holds it to his head while your partner's still laying on the ground, semi-conscious, and tells you, "Give me your gun." What do? Well, if you say, "I would give you my gun because I want to save his life," then they tell you, "Oh my God, you would give your gun away? Oh my God, bro." And then we'll see if you change your answer. Or if you say, "Well, I would take my gun out and I would shoot him. I would shoot the bad guy." Then they would say, "Oh my God, you wouldn't even try to negotiate." So again, whatever answer you give is wrong. So the terminology is, "Well, I would end the threat." That's the right answer. Is right now the threat is this lunatic with a gun, right? So I would have to end the threat. So they literally teach you to depersonalize the situation. It's not, "I would shoot the bad guy or the suspect." It's, he's a threat. He's an inanimate object, and I would end the threat. But these people aren't trained that way. They have trained themselves that way. And it's not just a threat. It's every person. Every person is an object. And so whatever needs to happen to that object, it gets moved, it gets shoved to the side, it gets overcome, it gets lied to, it gets whatever. So it's really interesting the way that they see the world. Impulsivity or failure to plan ahead, you will see them make the same mistake over and over and over and over again. They don't learn from their mistakes often. Um, Very impulsive in their actions. They just don't have the ability to um, think things through in the heat of the moment. Now, your Ted Bundy's, obviously a psychopath, can think things through as far as planning out a murder. That's different, right? But they're very impulsive when it happens, in the heat of the moment, right? When their arousal level is up, they lose all inhibitions, all ability to plan ahead. Um, Irritability and aggressiveness, obviously, reckless disregard for safety, again, because people are objects, they don't care. Consistent irresponsibility, of course. Lack of remorse. That one, lack of remorse and deceitfulness are the two that I think you almost always see. And then you might see one of the other ones or several of the other ones, but those two are I think the most common. Where do we get the terms psychopathology and sociopathology or sociopathy? They're just pop psychology words, basically. You do hear psychopathic or psychopathic traits mentioned by psychology because there is an actual checklist called the Hare Psychopathy Checklist, written by a guy named Hare, last name Hare. And it's a list of common traits, most of this stuff, but it's like 38 questions. It's quite long. Not quite long, but I mean, it's longer than this. And, you can rate people as to what it's a factor 1 psychopath, factor 2 psychopath, meaning like how many of those 38 things does he do? Is he a high level psychopath or a low level, mid level psychopath kind of thing? I mean, any psychopath is bad, but you can actually sort of, enumerate what their issues, their particular personality disorder creates for them. So you'll hear that term used a little bit because there's a little bit of science behind it. A sociopath, I don't usually hear that word used except in like Hollywood stuff, and kind of the way that I've heard it to describe to me that makes sense is if you're talking about an individual and the harm that they do, you talk about a psychopath. If you talk about somebody who has harmed a society, you like Bundy or John Wayne Gacy. I mean, they terrorize their communities, right? David Berkowitz, Richard Ramirez. I mean, some of these people. I mean, people were afraid to go outside. David Berkowitz. He was the son of Sam Killer. He killed couples that were making out in cars. He was just jealous that he couldn't get a girlfriend, so he went and shot couples while they were making out at lookout points, and then blamed it on his neighbor's dog. Said his neighbor's dog told him to do it, which was all just made up so he could try to beat the case on an insanity plea, which didn't work. But anyway, I mean, people were afraid to make out. People were afraid to, park in their cars and hang out because they didn't want to get murdered. The damage that he did to society, people, oh, he was a sociopath. He was literally out to hurt society. I think that's kind of a good way to differentiate these two things, but again, they're used synonymously, so I wouldn't worry too much about that. Couple of facts about antisocial personality disorder. Not all criminals have APD, and not all people with APD become criminals. There's actually a book, a really good book, and I can't think of the author, but it was called The Psychopaths Among Us, something like that. And it talked about a bunch of people that were CEOs and high-level attorneys, things like that, that have all of the criteria for anti-personality. Think about it. A lawyer, right? Think about O.J. Simpson's lawyers. Now, without getting into a debate about it, did O.J. do it? I think he freaking did it. There's not a question in my mind that he did it. I think most people believe that he did it. Do his lawyers think that he did it? I have no idea. All right. Let's just say, because most people think that O.J. did it, let's just say that at least one of his lawyers thinks, he might have done this, right? But they still got up on the stand, or in front of the jury, I guess I should say, and defended him zealously, right, as a lawyer is under oath to do. So are they failing to conform to social norms? Well, yeah, if you think that he did it, you should tell the jury that I think he actually really did this. He should probably go to prison for the rest of his life, right? Is it deceitful? Yes. Maybe this one doesn't apply. Maybe this one doesn't apply. Reckless disregard for the safety of self or others. Well, yeah, you're trying to get a murderer off the hook to go back out on the street. So, yeah, definitely reckless disregard. Is it irresponsible? I mean, well, what if all of your clients are like this and you take them one after another? Then, yeah, you maybe could do that. Lack of remorse. I haven't seen any of them fess up to it well after the fact. Some of them have retired. I think one or two of them have passed away now. I didn't see anyone on their deathbed saying, I really regret getting OJ off because, I mean, he absolutely did that, right? No remorse there. So we've got several of these for lawyers, and they weren't criminals. They didn't go out there and commit murders and, do these horrible things that like Bundy did and Dahmer and all these people. So it is possible to have this disorder and kind of turn it towards a socially sort of acceptable thing, like being a lawyer or, being a CEO. Or I think of like Richard Gere's character from Pretty Woman. Like he was rich because he bought all these struggling companies and then turned them around and then made them profitable and then sold them again. But he would buy like mom and pop companies and then fire everybody that worked there with no regard for them, and then fix it up, make it better, and then flip it for a profit. And he did all this just to make himself rich and didn't care about the companies or the people that work there. That's pretty sociopathic. So anyways, it's a scary that, we're living in a world that is creating more and more and more and more of these people, because we are more and more distant from each other, and we are further and further away from morals, and our moral compass is just not even existent anymore. So it's kind of scary. Couple of things. I'm not going to read the biology stuff, the attachment theory. Couple of myths. One of the myths is that psychopaths cannot experience love. That's not actually true. They don't demonstrate love the way that we would expect, but there are psychopaths that have had families and have kids and dearly love their kids and would die for their kids, like most parents would. They may not know how to show that or express it, but push came to shove and there was a bus coming. Would they jump in front of the bus for their kid? Yes. And there have been some cases of that where people have murdered and killed and, no regard for human life whatsoever, but, boy, you don't even look cross at their kid or they'll take your head off, right? I mean, that's love in a way. It's a very dysfunctional love, but it is love. So I think the best thing that I ever read about psychopathy, it talked about the notion this last thing, that psychopaths don't feel anything, right? They don't have any remorse, they don't have any guilt, and I actually don't think that's true, which flies in the face of almost all the research, right? But the reason I don't think that's true is because I think that they're human, and I think that we all experience those emotions, but some people wear it on their sleeve, right? Other people are a little better at suppressing it, and other people are absolute masters at suppressing it. And I think that's what psychopaths are. I think they can bury down that empathy and that feeling of humanity so deep that it's damn near repressed into the unconscious. And so it's not that they don't have the ability, which means they don't have the right chemicals in their brain, they don't have the right physiological structures in their brain to experience an emotion. That's what you mean when you say they are unable to feel an emotion. I don't believe that. I think they have those things, but they can on purpose direct it straight into this bottomless pit of suppression. They can rationalize and deny and all those Freudian things that we talked about, those defense mechanisms. They are masters at all of them. And whatever feeling they have, they can deal with it in an instant. They can suppress it. They can project it. They can, reaction formation, whatever, all those ones that we studied, right? They can just dispatch of those emotions instantly. Um, so, do they feel lonely and sad and rejected? Absolutely, I think they do. But they will tell you they don't feel any of those things because they've experienced it at a young age. They didn't like it. They learned how to work around it, and they have sort of become masters at it. So that's my belief anyway. Um, are psychopaths for life? Yeah, kind of. There's no pill that, like antidepressant, that will help it with it. There is no therapy that fixes any part of it. I have actually had one client when I did the forensic psychology internship, and he was a psychopath. He shot somebody in the face just to see how it would feel, and the guy didn't die. And so he got charged with aggravated assault and got a good lawyer and got probation, if you can believe that. And we talked for a good couple of weeks before he stopped coming, and it was just a game. It was just fun for him. It was kind of fun for me too, but he wouldn't get therapy out of it. He's never going to change. Is he ever going to shoot somebody else in the face? Probably. Yeah, I fully think he probably will, and that's what my report said to the court. But we'll see. So therapy doesn't help. Medicine doesn't help. Sometimes lifestyle changes make them a little bit less psychopathic with their behavior. I mean, a 70-year-old man is probably not going to beat you over the head with a hammer quite as quickly as that same guy when he was in his 30s or 20s, right? He's too old. He's tired, right? His gout is acting up, whatever the hell gout is, right? So sometimes there is a certain amount of aging out of some of the behavioral characteristics, but it doesn't mean that they're not a psychopath. It just means they don't act on it as much. So, all right, last slide. Thank God, finally. Even I'm sick of this one. Childhood disorders. There's a whole list of them. The new DSM-5 calls this one disruptive mood dysregulation disorder. I still can't say that. Disruptive mood dysregulation disorder. It's a disorder in which children are highly irritable and have frequent outbursts of temper that interfere with social and academic functioning. If you've ever seen this, it's unlike a kid throwing a temper tantrum. It's pretty mind-blowing. I mean, we're talking an outburst, and we're talking a temper that is unbelievable. And maybe every kid does that a time or two. I can think of one or two times that my son had just a temper fit. But these kids have them daily, like all the time. And when I was doing that thing with Magnolia, we had a couple of kids like this, and they were a handful, and they're dangerous. They can be very dangerous. So they need to be very closely monitored, in my opinion. Because their outburst of anger, I mean, there is absolutely, you talk about people being a danger to themselves and others. When you're that level of anger, you're not thinking about anybody's safety, including your own. So they can hurt themselves, they can hurt other people. Teachers will come in sometimes and try to restrain them improperly, and next thing you know, they're full on fighting this student. They're getting headbutted, they're getting bit, they're getting punched, kicked, slapped, pushed. I mean, it's just terrible. So these kids are, they definitely need an environment. I think a lot of times can be inpatient, like psych wards kind of thing, which no parent wants to put their kid there, right? But I also don't want my kid to get beat up by a teacher, or teachers grabbing them, bear hugging them, trying to calm them down, and they both fall, and they fall on top of my kid and hurt them or get hurt. So to me that's a really scary one to see. Children being that way because you can't just tackle them like you could maybe an adult because they're children, right? All right, so there's the ADHD. I kind of already mentioned that. I'm not really going to go into that one. And then autism spectrum disorder. I think people are pretty well aware of that one by now. Characterized by deficits in social relatedness and communication skills that are often accompanied by repetitive ritualistic behavior. It's called a spectrum disorder if you didn't know, because you can be very high on the spectrum, which used to be called Asperger's, and they did away with that. and then the very low. You can be very like high functioning autistic or very low functioning autistic. So, oh my God, that was the longest thing. I think it's the longest I've ever talked at one time without taking a breath. Thank you for sticking through it. Hope you didn't have to watch this more than 7 or 8 times to get through the whole thing. One more chapter to go. 20 or so more minutes of my voice, and you'll never have to hear me again. You guys take care, and I'm going to go to bed. Good night.